areas that we'd like to explore. And I'm extremely pleased with the way it's turning out to be with the Cambridge Medical Seminars. We have an excellent faculty setup today, and we have got two excellent moderators who are going to join me, Dr. Fraz Mir as well as Dr. Joseph Cherian. And basically, when we looked at the topics that we are going to be dealing on this weekend as well as on the next weekend, we tried to make it as heterogeneous as possible, because all of us in clinical practice knows that things can certainly go wrong in even the most innocuous situations. So we tried our best to see that we are trying to cover all the bases, and in case you have any suggestions on what we might add the next time, please feel free to do so. Today basically we are going to cover cardiovascular medicine, and I'm happy to ask Dr. Joseph Cherian to give us a brief background about the way they have been doing the seminars and about the Cambridge Medical Seminar in general. Joseph, on to you. Dr. Cherian, could you unmute yourself? You cannot be heard.
Hi.
Dr. Cherian, you need to unmute yourself. Yes, that's good.
Thank you very much for attending this first meeting of ours from Cambridge, live from Cambridge, and through to all of India. We're very excited about this program that we've lined up for you, and we hope that you'll enjoy it as much as we have in trying to prepare it. I thought I'd just explain to you how we came about, and of course a bit of history about Cambridge. So Cambridge started as a small trading town a long time ago, and in fact the hospital was built around 1112, and soon after the city became much richer, and some scholars in Oxford caused some nuisance, and they were persecuted, so they fled to Cambridge to set up a new educational hub in 1209, and the university has grown from there and was eventually given a charter by Henry III to start a university. Over the next few hundred years, various famous people have come through Cambridge, as you'll know, Sir Isaac Newton, and various famous events such as the Cambridge Boat Race, Oxford Boat Race, have come into being. More recently, we've celebrated our 800th anniversary in 2009, and you'll also note that Cambridge has the largest number of Nobel Prize winners in the world since 1904. Now, the hospital that we work in started in 1776 as a small unit with a small donation from Sir John Addenbrooke, and he set this hospital up to try and help the poor. And it started with a very small number of beds, and of course, as you can imagine, over the years this has expanded. The first bedside clinical examinations were started by Paget in 1842, and in fact the building that originally housed the hospital is now our Judge Business School. The hospital grew, and after 1948, when the NHS was formed, a new hospital was built in South Cambridge, which is where we are now. And the clinical school actually was formally only started in 1976. Our clinical students used to go elsewhere for the clinical years. And more recently, we have been one of the largest hospitals to receive the research funds, the largest research funds in the UK. And so we're now growing to be the largest biomedical campus in Europe. So we're very excited. And of course, some of the scholars, I wouldn't call myself a scholar, but Fraz and I stayed in Cambridge, and we found that there was a lack of postgraduate education, and there was shrinking study leave budgets. So we started this Cambridge Medical Seminars to try and bring the pool of academic clinicians from Cambridge to give talks to our trainees. Events here, and we've started a collaboration with the Royal College of Physicians and Sunway Medical Center, and we've started 2 physical meetings, and we're planning to take that online as well. So we have a small team, and we're very excited to be part of this event, and we would like to thank, of course, Sun Pharma for contributing significantly. And we hope that the program, today's program, will start with acute VTE and ECG, markers of sudden death, and more on the geriatric sort of side of things, from a whole host of as it should be practiced today. So we again thank Sun Pharma for their contribution and their support, and also thank MediQuest for helping us making this possible. And without further ado, I'd like to introduce our first speaker, who is Dr. Will Thomas. Dr. Will Thomas is a consultant hematologist at Cambridge University Hospitals and runs our regional hematology service for a number of conditions, including obstetric hematology, and we hope that his talk will be of interest to you. Thank you, Dr. Will Thomas.
Thank you for that. Can I just check when you can see my screen?
Yep.
So I'm going to give you an update on acute venous thromboembolism and some areas which people find tricky and which commonly come up in clinical practice, and also tell you my approach, which you may or may not find useful. So these are my conflicts of interest, which are relevant because they relate either to direct oral anticoagulants or to reversal of direct oral anticoagulants. And I'm going to talk about the 5 following things: D-dimer testing, cancer screening after venous thrombosis, the use of IVC filters, duration of anticoagulation in the longer term after unprovoked venous thromboembolism, and at the end touch on COVID-19 and thrombosis, which has gained worldwide interest during the current pandemic. I'm going to try and talk you through in a kind of case-by-case discussion way. So we'll start with a 77-year-old man who is out playing golf, swings his club, and develops some pleuritic chest pain, comes into the ambulatory medicine unit and has a normal physical examination. He has normal blood tests, you can choose what you like, a normal chest x-ray and a normal ECG, normal observations. So a fairly typical case. And the differential here could be a pulmonary embolism versus a musculoskeletal injury. And the one blood test that I haven't told you the result of, but which is really relevant here. But first, before we do the blood test, we do our 2-level Wells score. It's unlikely he has a PE on the 2-level Wells score, but we do his D-dimer, and it's 672. So if you're a cricket fan, Geoffrey Boycott would call that the corridor of uncertainty, because the uncertainty here is whether he has a PE and whether he should be scanned or not. So what's the background of the D-dimer? So D-dimer is a breakdown product from fibrinogen. So fibrinogen physiologically is turned into fibrin polymers by thrombin, and then factor 13 cross-links your fibrin strands to make a strong cross-linked fibrin molecule. And then the breakdown product of it, this is the D-dimer molecule, which is shown here by plasmin, and that's what we measure in the laboratory. So D-dimer has roughly a half-life of 8 hours. So if you leave a sample in a test tube for 8 hours, even a positive sample may be negative if you leave it overnight. So that's kind of a pitfall, and the levels fall by 75% 7 days after an initial thrombosis. So at Addenbrooke's, we do see a number of patients who present with VTE symptoms 2 to 3 weeks after they started. So you have to be aware that they may have normalized their D-dimer, and that's because of the tension between production of D-dimer and clearance of it. These are immunological assays, so you could broadly say that they're kind of ELISAs. There are a number of techniques, but they're all immunological. And it's confusing because reference ranges vary between manufacturers' kits and also hospitals. They're unreliable if patients are on anticoagulation because of suppression of thrombin generation for patients who are on anticoagulation. And as I said, they're stable for 8 hours in the test tube after blood draw. And of course, we know that whilst they are highly sensitive, raised in the following conditions. So they are not very specific at all. And COVID-19 is of great interest in this regard, and I'll talk about that further at the end in the D-dimer. So this is our current UK based practice, and the key here is it says when using a D-dimer test, consider using an age-adjusted D-dimer test for patients over 50, and that could allow us to reduce the number of scans that we do for patients needing or with suspected thromboembolism. So that's what I'm going to briefly talk to you about now. So this was the Adjust PE study, which really first brought this issue to the attention of physicians. And there were 2,898 patients who had a low clinical pre-test probability of thromboembolism included in the study. And what they found is that for patients with a low pre-test probability and a D-dimer between 500 and 10 times the upper limit of the patient's age, you could safely not do a scan, and the rate of PE at 3 months follow-up was 0.3%, which is acceptably low not to do a scan. So to give you an example of that, for a 77-year-old, your D-dimer threshold would be increased from 500 to 10 times the upper limit of age, so it would be 770, which allows you to scan less patients, which is advantageous to overstretched radiology departments. And so we can see here that they had 337 patients in the study with a D-dimer greater than 500 but less than 10 times the upper limit of their age, and there was only 1 thromboembolism, so very low rates in the age-adjusted cohort. That in some ways can be quite complex to use for busy clinicians on an ambulatory care unit, or who have lots of competing demands to think about. So this paper by Clive Kieran was published last year. I should say, very sadly, Clive Kieran, who's one of the giants of thrombosis, died a few weeks ago. So patients with a low pretest probability and a D-dimer less than 1,000, so they used a blanket value of 1,000, did not undergo scans in this study, and they were followed up clinically for 3 months, and they were scanned if there was any subsequent suspicion of PE. And so this was a study for people with suspected pulmonary embolism. And here were the results of it. So for patients with a low pretest probability, so these were people with a low Wells score and a D-dimer less than 1,000, they had 1,285 patients, and at 3 months follow-up, none of them had a pulmonary embolism. So that's a very satisfactory way of managing the patients, and it's less complex than the age-adjusted D-dimer. And you can see here that for that cohort of patients, so 1,700, if you do 315 less scans, so it's quite adjusted D-dimer. You do make a saving of 187 scans. It's perhaps not as you managed to save more with this algorithm published last year. So we can use a threshold of 1,000 nanograms per mil for patients at low risk for PE, so people with a low Wells score or unlikely probability, perhaps easier to use than the age-adjusted D-dimer. I should say that pregnancy in D-dimer remains extremely controversial. Something called the years algorithm has been published, in sort of score or algorithm in combination because of a UK-based study which suggested that D-dimers may be falsely negative in pregnancy in patients with thromboembolism. So in the UK, we are still not using the D-dimer in pregnancy because of concerns it may be falsely negative. And in the UK, we are still scanning people just based on clinical suspicion. So that ends the D-dimer part of the talk. And on to cancer screening. So this is something that still crops up quite a lot. And this is because of the concern that patients with unprovoked thromboembolism may have occult malignancy. So this is a very typical case, a 68-year-old woman with a past medical history of high blood pressure and type 2 diabetes, usually fit and well, works in a post office, who's diagnosed with a proximal right leg DVT, starts oral anticoagulation, and her leg returns to normal after a few weeks. She has a normal physical examination and systems inquiry, a normal set of blood tests. And the question is, should you offer a CT abdomen and pelvis to look for cancer? So in a New England Journal published study of 862 patients, where around 420, 430 were assigned either to limited screening or extensive screening, including a CT abdomen and pelvis. They then followed them up to look for the development of malignancy. And these were the results. So if you look at the blue line, this is the Kaplan-Meier curve, and on the x-axis is the time in months, and on the y-axis is the percentage of undetected cancers. So at 0 months it will be 100% for both groups, and you can see that over a 10-month period there's no significant difference in the two Kaplan-Meier curves for the percentage of patients in either arm, be it limited or limited screening plus a CT abdo pelvis, who had undetected cancer. So the conclusion from that is that the rates of the prevalence was low. It was less than 5% for occult cancer in the study, and routine screening with a CT abdomen and pelvis didn't provide a benefit to the patient. So on that basis, the NICE guidelines in the United Kingdom no longer recommend extensive cancer screening for people with unprovoked thromboembolism. My recommendation would be that they should have these basic blood tests and also a thorough physical examination, including a breast examination for women, but that routine testing with a chest X-ray in people with a DVT and a CT abdo pelvis for patients with either a DVT or pulmonary embolism is now no longer necessary. So on to case 4. So this is IVC filters and dealing with this contentious issue. So case 4 is a 47-year-old man with a leg cast, which has provoked a femoral vein, deep vein thrombosis several weeks after he's had the cast fitted. And he goes on to an oral anticoagulant, and 6 weeks later he has an upper GI bleed leading to a hospital admission. Perhaps he has a 1-unit blood transfusion, and he has a upper GI endoscopy which shows a peptic ulcer, which he has perhaps clipped, or he has endoscopic therapy. And in that time, he has a 48-hour break from anticoagulation envisaged. Perhaps after that, he can restart prophylactic dose low molecular weight heparin before escalating to perhaps an intermediate dose of low molecular weight heparin. So the question is, and this is a very common occurrence, we probably asked this in the hemostasis service at Addenbrooke's on a weekly basis, should we insert an IVC filter? And the background to this is physicians are extremely worried that patients will develop further thrombosis and pulmonary embolism, which will harm the patient. And an IVC filter has the potential to decrease rates of DVT embolization to the lungs. The reason being that PE can cause fatality. So here are some very general considerations which I always take into mind when I'm phoned, and I actually work through these principles for every single case. And when our registrars come to us with these cases, I try and take them through these considerations. So we know that factor 13 takes 3 weeks to stabilize clots. That's the biology of coagulation. So after 3 weeks anticoagulation, your clot is relatively stable. We know that the risk for untreated acute venous thromboembolism is around 40 to perhaps even 60% over 3 months if you do not treat it. But actually, what nobody knows is what happens if you give someone 3 weeks of treatment or 4 weeks of treatment, and then you have a 1, perhaps 2, perhaps a 3-day break from anticoagulation. And even if the risk is 60% over 3 months, that equates to 60% over 90 days, which is less than a 1% recurrence risk per day. So the absolute risk over that 90 days may be high, but the daily risk is relatively low, especially if they've had any prior anticoagulation. And this is what I've alluded to, but if the patient's had a period of full dose treatment, this figure is likely to be lower, and therefore a 48-hour break from anticoagulation is likely to be relatively low risk. And we ask this: what's the anticipated break in anticoagulation? If someone told me a patient had had an iliofemoral DVT and a massive GI bleed that could not have any anticoagulation for 2 weeks, 24 hours after the DVT was diagnosed, my perception is that would be very high risk for embolization, because it's a large, very proximal clot that's received very little treatment. In this case, for this gentleman, he's had 6 weeks of full dose therapy, and so the clot will be nice and stabilized. So the harms of an IVC filter also need to be balanced, and they include the risks of not being able to retrieve it, bleeding at the puncture site, infection, also clot migration, clot fracture, eroding through the IVC wall, and also the fact that patients with IVC filters tend to be left on lifelong anticoagulation in the absence of any evidence for that, because of the risk of developing thrombosis around the filter site with subsequent post-thrombotic syndrome, which unfortunately is quite common. So I'll very briefly present the 3 seminal studies, or in my opinion, the 3 seminal studies in this area. So they're in kind of a slightly funny order, but this study was published 2 years ago, and it's a retrospective study from the United States of 126,000 patients, where an IVC filter was inserted in those hospitalized who had a contraindication to anticoagulation, that had had venous thromboembolism. And what they found was that the patients who had an IVC filter had a hazard ratio for death of 1.18, which was significantly increased compared to those who did not have an IVC filter inserted. When they did that study, they had to adjust for immortal time bias, because the study is inherently biased, because if you got a filter inserted, you could not die prior to having the filter inserted to be able to go into that arm of the retrospective study. So it was appropriately adjusted for that bias. But the important thing of that study, albeit retrospective data without randomization, is that the patients that had an IVC filter actually had a higher risk for death. And then the 2 randomized studies in this area were the PREPIC-1 and PREPIC-2 study. So in the PREPIC-1 study, which is now 22 years old, patients with a proximal DVT were managed with anticoagulation plus or minus a permanent IVC filter. And what they found was, in the group that received an IVC filter, there were lower rates of pulmonary embolism, 1.1% in those that got a filter versus 4.8% in those that did not. But in long-term follow-up, they found that DVT was increased in those with a permanent filter, recurrent DVT of 20% in the IVC filter arm versus 11% in the non-IVC filter arm. So what we can say is for people with DVT, it reduces the PE rate, but at the expense of long-term DVT risk. Unfortunately, the limitation of this study is that it was done on people on anticoagulation, so we don't know how that equates to a population who have a temporary break in anticoagulation for, say, an operation, or they have a GI bleed. And then PREPIC-2 was published 5 years ago, and for patients with PE, they were treated with a temporary IVC filter plus anticoagulation or anticoagulation alone. And what they found was there was no difference in the rate of recurrent pulmonary embolism or death in either group at 6 months of follow-up. So for patients with PE, there seems to be basically zero benefit from having a filter, albeit a study where both arms are on anticoagulation, so not really applicable to current practice where IVC filters are not routinely inserted. But I think it's useful to know that background. So this is the current guidance in the United Kingdom, which says do not offer a filter to people with proximal DVT or pulmonary embolism unless it's part of a clinical study, or anticoagulation is contraindicated, or PE has occurred during anticoagulation treatment. And so we occasionally insert filters for this indication when anticoagulation is contraindicated and the patient's within, say, 2 to 3 weeks of an acute thrombosis. But for patients who have a PE during anticoagulation treatment, I have never inserted an IVC filter. And our general approach would be to either escalate their anticoagulation to perhaps warfarin with a target INR of 3 to 4, or to empirically switch the patient to an anticoagulant with a different mode of action. So if they're on a DOAC, we might switch them to warfarin, or if they're on a warfarin, we may switch them to a substrate inhibitor such as heparin or a direct oral anticoagulant. So this is, as I say, the main group that we put filters in, people who have an acute proximal DVT or pulmonary embolism, who have an absolute contraindication to anticoagulation, and who we perceive as having a high risk of death from their thrombosis. And for me, that would be someone with a iliofemoral DVT who has had less than a week of anticoagulation would be the people I really worry about, who are going to have more than, say, 48-hour break from anticoagulation. And the key is when the filter is no longer needed because anticoagulation treatment's resumed, remove it. Otherwise, you incur the side effects of having a filter for the rest of the patient's life. And one strategy is that when you request the filter in your radiology departments, that the radiologist reflexly add a removal request onto the hospital's radiology system would be one solution to that. So we'll move on to the next case, which is kind of the biggest question in hematology or thrombosis medicine for hematologists, which is what is the optimal duration of anticoagulation for patients who have had unprovoked deep vein thrombosis or pulmonary embolism? So this is a very typical case, a short caveat, but a 44-year-old man, usually fit and healthy, weighs, say, 85 kilos, who comes to clinic. He's had an unprovoked bilateral pulmonary embolism, and he's had 3 months worth of direct oral anticoagulant, and he wants counselling about the long-term options. So current guidelines from the International Society on Thrombosis and Hemostasis stipulate that if your recurrence risk at 1 year is less than 5%, once you've stopped anticoagulation, and at 5 years less than 15%, again, once you've stopped anticoagulation, then it would be reasonable to say to the patient, don't continue long-term anticoagulation. So there are some ballpark figures for trying to ensure patients that we stop anticoagulation for have recurrence risks less than. So this is a systematic review which was performed, and what the authors of this study did was they equated the clinical context of the patient's proximal DVT or pulmonary embolism to the recurrence risk per annum in the years after stopping the initial 3 to 6 months of anticoagulation. So we know that patients who have had a transient surgical risk factor, so if we say hip replacement or a cesarean section are the two classics, they have a recurrence risk for their thrombosis of less than 1% per year. They're extremely low risk of recurrence should they avoid any further provoking factors. And then for transient risk factors such as the combined pill or perhaps a period of immobility, the risk per year is around 4.2%. So again, it's that slight grey area there. They're in the middle because patients with unprovoked venous thromboembolism, where there's no identifiable risk factor, have a recurrence risk of 7.4% per annum. And then if you lump together the non-surgical and surgical risk factors, the recurrence risk is around 3% per year. And I should say distal DVT, so that occurring distal to the popliteal vein and its trifurcation, has a less than 2% recurrence risk per year and does not need long-term anticoagulation. Our local practice is to treat it with 6 weeks worth of anticoagulation, though I will recognise that's controversial and not all doctors would say distal DVT does need anticoagulation. Our experience in Cambridge is that patients that present to us expect treatment. Whether that's the right thing to do is a matter of intense debate in the haematology world. But these are some ballpark figures to talk to your patients about, and which I always quote in clinic. I find extremely useful for giving people information. And I use this model for our patients for the risk of recurrence, which goes from 0 to about 5 to 10% per year. So major surgery has a negligible recurrence risk. And then as you accrue more minor risk factors, it goes to 3 to 4% per year. For unprovoked clots, you get up to your 5 to 10% risk per year. And then really at the top end, you have your patients who have ongoing major risk factors for thrombosis, and they would include patients with active cancer, especially metastatic disease, who will be extremely high risk of recurrence. So the question is, does where you have your clot matter? And this is a meta-analysis of previous studies, which included 2,500 patients with venous thromboembolism who stopped their anticoagulation, and the recurrence risk was 22.6%. The crucial thing is that the recurrence risk, if you have a PE, was 20, this is for unprovoked events, I should say. The recurrence risk was 22% for PE, but the recurrence risk is also the same or not significantly different for people who had DVT. So if you have an unprovoked PE or DVT, the recurrence risk is the same. The thing to realise, and which is helpful when counselling your patients, however, is that if you have an unprovoked PE and you stop anticoagulation, if you have a recurrence, there's a 50% chance that it will be as another PE. However, if you have a deep vein thrombosis and you have a recurrence, there's only a 15% chance it will be as PE. So this is extremely useful information for counselling your patients. The reason being is if you have a popliteal vein DVT and you have a recurrence, it's very likely to occur in the same vascular bed, and patients therefore may be inclined to stop their anticoagulation because although there's roughly a 30% chance of recurrence over 5 years, it's very likely to be again as a popliteal vein DVT rather than as a PE. On the other hand, if you have a massive pulmonary embolism and you were told there's a likelihood of having another PE should you stop anticoagulation, in my experience, the majority of patients will elect to continue anticoagulation. So if you have your first event of the DVT, you're likely to recur as a DVT. Your first event of the PE, 50% chance of recurring as a PE. So they're very useful stats. And does the size of your pulmonary embolism count? So this is a retrospective study of 100 patients which we did a few years ago at Addenbrooke's, and we found that irrespective of whether your first PE was submassive or massive in one category versus what we could just say a small PE, so whether it was big or small, the risk of having a submassive or massive PE at recurrence was 15%, irrespective of the size of your first clot. So that's very useful information for counselling patients, because you can say to them, the size of your first clot does not predict the size of your second clot. So having a PE predicts that you will recur as a PE, but it does not predict how big the PE will be at recurrence. And then this is a study of far more patients from the RIET registry, and they looked at whether your the size of your index PE, be it massive versus non-massive, predicted your risk of recurrence, and they found a hazard ratio of 0.81, which passed through 1, so it was non-significant. So whether your PE was big or small, it didn't predict whether you would get another PE. That's determined by whether it was provoked or unprovoked. So this is probably one of the most seminal papers in thrombophilia, which was published now nearly 20 years ago. This was published by my predecessor at Addenbrooke's, Trevor Baglin. And what he did was he followed up patients with PE or DVT who had completed their initial 3 to 6 months of anticoagulation, and he followed them up for 2 years to see what happened to them. And on the x-axis is the time in months, and on the y-axis is the cumulative proportion of patients who had a thrombosis recurrence. And Dr. Baglin found that patients with thrombophilia, which is indicated by this solid black line here, when he did thrombophilia screening for protein C deficiency, protein S deficiency, antithrombin deficiency, factor V Leiden prothrombin genotype, had an indistinguishable recurrence risk to patients without thrombophilia. So I know that the cumulative proportion lines do separate here, however that's not statistically significant. So your thrombophilia status paradoxically does not seem to predict your VTE recurrence risk. So we do not do thrombophilia screens to help predict patients' outcomes. And then what's your acceptable risk of bleeding and recurrence rates per year? So what are the risks related to those? So if you stop your anticoagulation after an unprovoked PE or DVT, there's a 0.3% chance you will die from an event per year. Should you have an event, the death rate is 3.6%. And we generally say for patients taking warfarin that the major bleeding rate's 2 to 4% per year and 0.2% for intracranial hemorrhage. And if you have a bleed, your mortality will be around 12 to 15%. So in totality, we can say if you have a major bleed, your mortality is 3 to 5 times higher than recurrent VTE, because 11% here is roughly 3 times higher than the case fatality rate for recurrent thrombosis. So again, it's helpful information to give to our patients. The other thing we can do to help predict recurrence for thromboembolism is a D-dimer. So after 1 month after stopping anticoagulation. So in this study published in the New England Journal, 608 patients had a D-dimer who had had an unprovoked VTE. They had the D-dimer done 1 month after stopping anticoagulation. It was increased in 36.7% of the patients. Of these 36.7%, they were randomized to either stop or to continue anticoagulation. Those who stopped anticoagulation had a 15% recurrence rate, and those who continued anticoagulation had a 2.9% recurrence rate. So, and of people, the 2/3 of patients with a negative D-dimer, 6.2% had a recurrence. So what you can say is a high D-dimer predicts recurrence, a negative D-dimer predicts a relatively low rate of recurrence and could help patients decide on duration of anticoagulation. So some conclusions: distal DVT, 6 weeks of anticoagulation and discharge. Unprovoked or potentially weakly provoked VTE, you need to talk about long-term anticoagulation. You can use the has-bled risk, although it's an AF tool, it can be used for VTE to discuss bleeding risk, and then discuss the following risk factors for VTE recurrence, which I find helpful and help in the kind of matrix of decision making. And you can use your D-dimer if you're unsure and the patient wants a kind of yardstick, am I high or low risk of recurrence? And the other option is a low-dose DOAC, which has a relatively favourable bleeding profile and is extremely convenient to help prevent long-term recurrence, and is more convenient than vitamin K antagonists. So the final part of the talk is about COVID-19. So COVID-19 caused a storm in the hematology community and causes profound inflammation and increase in coagulation markers, including the following: so fibrinogen, your factor VIII and D-dimer, VWF, a mild decrease in antithrombin, and diffuse endothelial dysfunction, but particularly in the lungs. But what we don't see is prolongation of the coagulation test commonly done in the lab, and we don't really see thrombocytopenia. So it's not typical for DIC. It's something else. This is some data from China, which was published very early on in the pandemic, and they plotted patients' coagulation parameters throughout 2 weeks of admission. And in the blue bars, there's survivors, and green bars, non-survivors. So they found that the non-survivors tended to have longer prothrombin times. They tended to have longer APTTs. They tended to have higher D-dimers. They tended to have lower fibrinogens in the terminal phase of their illness. And in the terminal phase of their illness, they had lower antithrombin levels. So this is some data from Addenbrookes Hospital Intensive Care Unit. And this shows the cumulative instance of thrombosis over 25 days for patients in our intensive care unit who were admitted with COVID-19. And you can see it's up to roughly of PE, line thrombosis and MI. So that's relatively high rates and is compatible with other published data in the literature. And these are just the early papers, because there have been many more since. It's impossible to show them on a slide, but the clock paper had a 30% cumulative incidence of thrombosis in the ITU in Holland, a 25% prevalence of DVT in the China ICU paper, a 17% prevalence of PE, and 96% prevalence of hemofiltration thrombosis in the circuit. Saskia Middledorp's group showed a 40% thrombosis rate in ICU patients and 3% in ward patients. The ward patients is probably about the same as we'd see for non-COVID ward patients. And then Beverly Hunt and Mike Desborough published this paper, which showed that if you exclude small peripheral PE, the rate of line thrombosis and central PE is actually 5%. So they kind of have disputed the figures that the rest of us have published. And that's because they say that the PE may be peripheral and represent in situ thrombosis caused by localized inflammation and filling defects in the pulmonary circulation. There have also been these case reports published of patients developing unusual arterial ischemia. This is a patient from Ross Davenport's group in London with a thrombosis in the aorta here. And so there is this unusual association with arterial thrombosis. I don't think the true rates are known. We've had 2 MIs in our intensive care unit. And then there's this interesting report in the New England Journal of Medicine that reported cerebral ischemia and antiphospholipid antibodies in a patient in some patients in China, and then the Royal London reporting very high incidence of a positive lupus anticoagulant. And it's unknown if that's responsible for the thrombosis in these patients or whether that's an epiphenomenon that's just transient. And there have been these reports of whether heparin could increase survival in patients with COVID-19. So this is the 28-day mortality, and you can see for patients with a D-dimer greater than 8 times the upper limit of normal, the survival rate was significantly, or the 28-day mortality was significantly higher in patients that did not receive heparin versus those that did. And so this was a Chinese paper for patients with COVID. So that's an unanswered question. We found high rates of heparin resistance. Up to 70% of patients in our intensive care unit have had heparin resistance, including that to fractionated heparin or to subcutaneous low molecular weight heparin. And we've found that if you spike COVID plasma with heparin, you get decreased recovery of the anti-10A activity compared to control plasma. So we don't really understand why. We don't think it's due to antithrombin deficiency, but several other groups are now beginning to find the same. So we came up with this algorithm for thromboprophylaxis at our hospital. In ICU, we doubled patients to twice daily prophylactic low molecular weight heparin. On the wards, we give once daily prophylactic low molecular weight heparin. We don't give stockings for medical patients. And then at the point of discharge, 2 weeks of prophylactic low molecular weight heparin or low dose rivaroxaban. And for outpatients, we can consider 2 weeks thromboprophylaxis if we could perceive them to be at very high risk for thrombosis. And then this is unpublished data, which is a joint effort between our group at Addenbrooke's and the group at St Thomas's Hospital led by Beverly Hunt, for the cumulative incidence of thrombosis from our 2 intensive care unit cohorts. And the cumulative incidence of thrombosis for the patients in intensive care, when you follow them up long term, up to 100 days of follow-up, is only 18%. So it's lower than those original papers which suffered from a number of biases and which did not have good long-term follow-up. So the rate appears to be 18%. However, if you deduct small peripheral PEs, which may represent this in situ immunothrombosis, the rate of thrombosis appears to be more like 4%. So it's a great unknown whether these patients, what the significance of these early small peripheral PEs are. The one thing to notice is all the clots really occur at the beginning of the admissions, the first 3 weeks, and very few later on. And recently the team at King's College Hospital in London found a rate of post-discharge VTE of just 0.5% for patients with COVID, which is really very low and in itself would not justify extended doses of thromboprophylaxis, extended courses. So to finish, the role of heparin in COVID-19 remains non-evidence-based, and whether it increases survival or whether you should be escalating doses is unknown, and you're justified in not doing that. I've talked about in situ pulmonary thrombosis. And whether COVID-19 coagulopathy is a misnomer and it's really just the endpoint of extreme inflammation with a high fibrinogen and high D-dimer as a consequence is something I think that's emerging. How do I manage VTE? If patients have COVID, I say it's a provoked event, and I advise 3 to 6 months of anticoagulation with either low molecular weight heparin or DOAC. And then I stop and I assess the patient at that point, and if they're well, I say that's a provoked event and I discharge them. And optimal thromboprophylaxis after discharge, well, all inpatients should have VTE risk assessment plus or minus thromboprophylaxis, but whether patients need post-discharge thromboprophylaxis at all maybe isn't justified based on the paper by Rupen Ayres group at King's and also the data I've just shown you from our intensive care unit study. So I'm open to questions now. And I hope you enjoyed the talk.
Thank you, Dr. Thomas. That was a very nice summary of the anticoagulation. We've got some questions coming up, and I think Dr. Joseph and I will just share the duties on that. So let's begin with a very basic question, and that's regarding the number of assays which are available for D-dimer. The last time I counted, there were more than 30 assays, and that's quite confusing. Why is there no standardization of these tests? Because in our part of the world, people come from different places to the hospital, and they carry reports from different labs, which causes a lot of confusion. So could you share some light on that?
Yeah, so I think this is an area that needs to be made standardized and which would benefit from being made a project at the ISTH even. One of the difficulties is the units differ. So some assays use the fibrinogen equivalent unit, but our local lab uses the D-dimer unit. You have to double the D-dimer unit to get the approximate fibrinogen equivalent unit. So we know that the assays often compare very badly. My advice is that if you are going to implement either the age-adjusted D-dimer or one of these algorithms that allows you to tolerate a higher D-dimer threshold to exclude thromboembolism, my strong advice is you locally try and validate that in your ambulatory care unit, because that's what we have done at Addenbrooke's when looking at this, to try and see what the performance is. But you're right, the kits are a massive problem in that they're not always comparable. The reason that they're not comparable, if I may say, is the assays are immunological, and the D-dimer fragment specificity of each antibody will differ. So that's why they're not comparable. And secondly, the interferences in the assay from things like rheumatoid factor differ between all the kits. So that's why they're not comparable.
Joseph, you got some questions for him?
Yeah, thanks, Will. So that was a fantastic talk. So one of the questions that's been posed today is D-dimer is more a rule-out test than a rule-in test. And can you comment on the negative predictive values and how these are affected by warfarin and DOACs? How long after stopping these drugs would a D-dimer be affected by these drugs?
Yeah, so I personally would say 1 month. The reason being that the studies looking at D-dimers for predicting recurrence risk were done 1 month after the anticoagulation was stopped. So therefore, I think that's a safe amount of time. I think if someone's been on anticoagulation in the past month and they present to you and there's that 4-week window, you're probably nearly obliged to rescan them. The reason being is because the anticoagulants inhibit thrombin generation, which may inhibit D-dimer formation, essentially. So they have a good, so outside of the anticoagulation role, sort of situation where patients haven't been on that, they've got a good sensitivity, poor specificity. So in that sense, they have a good negative predictive value. If the patient has a negative D-dimer, they don't have a clot. If it's positive, it could be anything.
There's a question which just came in from Pradeep Gupta. In his COVID patients, sometimes he notices that these patients have high D-dimer levels, but other tests like PT and APTT are normal. So how do you make sense of that?
Yeah, okay. So what we know about D-dimer is that it can be generated through excessive thrombin generation. And the way that you would determine excessive thrombin generation is if the patient had a prolonged PT and APTT, which would demonstrate that they've generated a massive amount of thrombin and consumed their clotting factors. That isn't really what we see with COVID. We see normal PT and APTT with a disproportionately high D-dimer. And one of the theories that has been going around for that is that that's generated locally in the pulmonary vasculature by the action of inflammation and UPA. So UPA and also macrophages can enzymatically degrade fibrinogen in the lungs or fibrin and can generate D-dimers, and that it's not actual global activation of hemostasis. So it seems to be a localized pulmonary effect.
We have another question on the duration of anticoagulation, and you did describe the typical duration for anticoagulation. But in a patient with recurrent DVTs, what's the longest that you would consider? And this is a question which came from Dr. Lal.
Yeah, so for a patient with recurrent VTE where one of the events was unprovoked, I would consider anticoagulating them for life. I think the situation that's quite tricky is where they've had 2 provoked events, and in that situation I might anticoagulate them for life depending upon the strength of the provoking factor. If it was a relatively weak provoking factor, I'd consider lifelong anticoagulation. But actually for a patient with a PE after 2 hip replacements, 1 on each side perhaps, yeah, I would still stop, or I'd consider stopping anticoagulation. So it's really dependent upon the strength of the provoking events.
Okay, well, one last question, just a quick answer. So a patient with a proximal DVT and PE who has a femoral fracture, when is it safe for the orthopedic surgeon to operate? How much time to treat, and then when do you stop, and how do you stop for the surgery?
I think that's a high-risk situation for thromboembolism. I think that the orthopedic surgeons are likely to need a significant break for surgery. If they need to do surgery within a week, yeah, that's a situation I'd put an IVC filter in for.
Marvelous. Thank you. Thank you very much, Dr. Thomas.
Thank you.
Okay, so we'll move on to the next talk today, which continues with our cardiovascular theme. And up for that, we have Dr. Greg Mellor, who is a consultant cardiologist at Royal Papworth Hospital in Cambridge. He has a special interest in cardiac electrophysiology, and he'll be telling us a bit about some important features to look for in ECGs and in patients who may be at risk of sudden cardiac death. So Dr. Mellor, over to you if you would share your slides with us now, please.
Well, thank you, Franz. Hopefully you can see the slides now. So as Franz mentioned, my name is Greg Mellor. I'm a consultant at Papworth Hospital in Cambridge, and we're going to talk this evening for you, this afternoon for me, about some of the diagnostic ECG features associated with conditions where there is a risk of sudden cardiac death. So unfortunately, sudden cardiac death is very common. This is 20-year-old data, but it almost certainly remains true that 50% of cardiac deaths are sudden in nature, and sudden cardiac death probably is responsible for around 10% of all deaths. And the end mechanism of sudden cardiac death, for the most part, is ventricular fibrillation. This is a 12-lead ECG that you should never see. The doctor should have been more preparing the defib pads than the 12-lead, but either way. This is the endpoint, ventricular fibrillation. We're going to focus this evening on arrhythmic cardiac death, most of which is due to ischemic heart disease. So either the acute consequence of plaque rupture and a complete occlusion of an epicardial coronary vessel, or the long-term consequence of a previous myocardial infarction. And this MRI scan shows a well-established scar here in the lateral LV wall, which can be responsible for ventricular tachycardia months or even years after the original event. However, around 1 in 8 sudden cardiac arrest survivors are found to have normal coronary arteries with an alternative explanation. And in those cases, we're talking about either the primary cardiac arrhythmia syndromes. So these are the ion channel disease or channelopathies, most commonly long QT and Brugada syndromes. Also, particularly in younger pediatric groups, catecholaminergic polymorphic ventricular tachycardia. And in patients with pre-excitation who also have atrial fibrillation. And then the second group are the heart muscle diseases, the cardiomyopathies, which are associated with a risk of sudden cardiac death. So most commonly that's hypertrophic cardiomyopathy, followed by arrhythmogenic, or used to be called arrhythmogenic right ventricular dysplasia, dilated cardiomyopathy, and finally, as already mentioned, ischemic cardiomyopathy. So what I'd like to do now is just run through a series of cases of a number of these conditions, focusing really on the ECG diagnostic features, but then also with some background on the conditions themselves. So this is our first case. This was a 28-year-old male professional footballer who collapsed on the pitch. He'd been complaining of chest pains in training sessions in the lead up to the game, and it was noted that his father had died suddenly and unexpectedly in his 40s. Thankfully, he recovered consciousness and was admitted to the emergency department, and physical examination was unremarkable apart from the finding of a systolic murmur. And this, as I said, is his 12-lead ECG. So I'll just talk you through this. So what we see here is sinus rhythm. The most striking abnormalities are the large QRS voltages, so particularly seen in the septal leads V2 and V3, but also in the lateral leads with V5 here in excess of 80 millimeters. Associated with this is lateral ST segment depression and T-wave inversion with deep peaked negative T-waves. So this is a marker of left ventricular hypertrophy, often with this associated strain pattern. Of note, the patient also has evidence of atrial disease. The P waves are of high amplitude in the inferior leads, suggestive of right atrial enlargement. And there's a biphasic positive negative P wave in lead V1, which is diagnostic of left atrial enlargement. So we can say from this ECG, this patient has significant left ventricular hypertrophy with biatrial dilatation. And this is diagnostic of hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a genetic disease. It's caused by mutations in the genes associated with the sarcomere. This is the structure responsible for contraction and relaxation of the cardiomyocytes. The end result is this massive hypertrophy you see within predominantly the left ventricle. So this is a pathological section, cross-section through the left ventricle. This is the aortic valve here, the left ventricular outflow tract, which is obstructed by a combination of the thickened septum and the mitral valve leaflets here. And then this is the rest of the mitral valve and the left atrium. As in our case, unfortunately, this has been responsible for the sudden death of several professional sportsmen, including these two footballers you may recognise, Mark Vivian Foe, who died during an international match playing for Cameroon, and Miklos Ferher, who died playing for Benfica in the early 2000s. The three features of hypertrophic cardiomyopathy are the manifest left ventricular hypertrophy with associated myocardial disarray on histology. So rather than nicely lined up straight lines of cardiomyocytes, you can see these are all pointing in different directions, which is responsible for the underlying conduction delay and associated re-entrant ventricular tachycardia. On top of that, these patients develop small vessel disease and ischemia, particularly within these very thickened areas. So again, this is the left ventricular septum, and you can see hopefully little patches of scar tissue caused by hypoxia from this small vessel disease within the septum. So hypertrophic cardiomyopathy is a common disease. It affects about 1 in 500 individuals and is a leading cause for sudden cardiac death in young to middle-aged adults. Not all patients with HCM are at risk of sudden cardiac death, and there are several known risk factors: a family history of sudden death due to HCM, the presence of previous syncope or non-sustained VT on a Holter monitor are all markers of sudden death, as is increasing septal width and left atrial enlargement. Within Europe, all of these factors are entered into a calculating algorithm that will give you a predicted risk of sudden death over the following 5 years, which will allow the decision about ICD implantation. Obviously, the diagnostic modality, in addition to ECG, is echocardiography. This is images from a colleague of mine, Dr. Williams at Royal Papworth Hospital. This first image is a parasternal long axis view. So again, now we have the hypertrophied interventricular septum here with the left ventricular outflow tract, and then the aortic valve here with the mitral valve and a dilated left atrium posteriorly. And then in the short axis view, this is now cutting through the left ventricle at the level of the mitral valve. So again, hopefully you can see, if my cursor works, you can see concentric LVH predominantly affecting the septum rather than the lateral wall. Okay, so moving on to the second case, and I'm purposefully jumping around from condition to condition here. So this is a 25-year-old female. She was working in a shop when she developed sudden onset rapid palpitations and felt dizzy. She didn't pass out but was brought to the emergency department in early cardiogenic shock with a rapid pulse and low blood pressure. It turned out she'd had a previous episode of syncope during school sports as a child, which had been put down to heat stroke. This ECG, I hope you agree, shows a broad, complex tachycardia, but notably it is irregular in its rhythm, and the QRS morphology is variable from beat to beat. So looking closely through, each QRS complex is different to the one before and after, and with no real pattern. And the rate is very fast, but it's irregular, with shortest RR intervals way above 200 beats per minute. So the patient was cardioverted. This is not her, but an example of a sinus rhythm ECG that hopefully demonstrates what the diagnosis is. This is ventricular pre-excitation, and this previous ECG is pre-excited atrial fibrillation. So an irregular, broad, complex rhythm with changing QRS morphologies can only be pre-excited atrial fibrillation. So Wolff-Parkinson-White syndrome is caused by the presence of an accessory pathway between the atria and ventricles, and it results in this diagnostic ECG pattern of a short PR interval of less than 120 milliseconds. And you can see in this example there's an absence of an isoelectric portion of the PR interval and a slurred onset to the QRS, which we call a delta wave. And this is caused because of this additional accessory connection between the atrium and ventricles, so that in sinus rhythm, signals are simultaneously conducted over the AV node and through the His-Purkinje system, but also over the accessory pathway, causing this area of the ventricular myocardium to be activated early. The conduction here is myocyte to myocyte and therefore is slow compared to within the His-Purkinje system, so that the normal conduction catches up, as it were, meaning that the second portion of the QRS complex is relatively normal. In the context of pre-excited atrial fibrillation, the main management step is not to give any AV nodal blocking drugs. Any medication or procedure that causes blockage of the AV node will preferentially lead to conduction over the accessory pathway. The accessory pathway does not exhibit the same protective decremental conduction properties as the AV node, and therefore can transmit the atrial fibrillation very rapidly into the ventricle, causing ventricular fibrillation. So in the acute setting, DC cardioversion is safer than any antiarrhythmic drug, all of which may also block the AV node. And then once the patient is stabilized, the class 1 treatment is catheter ablation to destroy this accessory pathway. Case number 3. This is an 18-year-old lady. She was working as an outdoor activities instructor. She's from the UK but was working in France, taking a group of school children around the Alps. And on this particular day, she was teaching them how to canoe, and specifically how to right the canoe after you tipped into the water. So for anybody who does canoeing, you'll know that to do this activity, you roll yourself into the water and then right the canoe back upright. Unfortunately, when this young lady went under the water, she didn't return and had to be dragged out by her colleagues. Thankfully, came to on the side of the river. And it turned out that she'd had several other loss of consciousness episodes while swimming as a teenager. So this is her ECG again, it's sinus rhythm, relatively bradycardic. And you'll notice that the T waves are of low amplitude with a fairly broad base, and they're inverted here in lead 1 with this late terminal negative deflection, and also in AVL. When you measure the QT interval on this ECG, the corrected QT interval is 490 milliseconds. The combination of a prolonged QT interval and the syncope on swimming led to a clinical suspicion of non-QT syndrome. She went on to have genetic testing and had this missense variant identified in the gene KCNQ1, which is diagnostic of non-QT syndrome type 1. So long QT syndrome is the most common of the ion channel diseases. It affects probably about 1 in 2,000, at least within European populations. And it's caused by genetic loss of function mutations in the potassium channels responsible for the repolarizing current of the action potential, or less commonly, gain of function mutations in the sodium channel current, leading to an overactivation of the initial part of the action potential. It causes a delay to the repolarization in the cardiomyocytes, which manifests as a prolongation of the QT interval on the ECG, and it causes sudden death by an increased risk of this very particular ventricular arrhythmia called torsade de pointes. There's large variation in the QT measurements in the normal population and in the disease population, and we'll come on to that shortly. Often the biggest challenge in diagnosing long QT syndrome is actually accurate measurements of the QT interval on a 12-lead ECG. We'll go through that shortly. In the bottom corner here is Professor Andrew Crahn, a former mentor of mine, who has a very excellent, if not a little bit long, YouTube video on just how to do this. But for those of you who don't quite have enough time, I will give you the short version. So the QT interval starts with the activation of the QRS complex. That's normally fairly easy to identify. First, you identify the isoelectric line, commonly through the PR interval, but if this is depressed, which it can sometimes be, from the end of the T wave to the following P wave. Then the onset of the QRS, as I said, is normally quite straightforward. It's the first deflection, so in this case, a small Q wave. And then the trick is identifying the end of the T wave. This is a fairly straightforward example, but there are others where the T wave morphology makes it more challenging. What we recommend is picking the maximum descent of the downward slope of the T wave, drawing a tangent through this point, and the point at which it intersects your isoelectric line is the end of the T wave. So you'll note that you do ignore these tiny little shoulders or potential second U wave phenomena that follow the T wave. And so that is your absolute QT interval. The second challenge then is to correct for the baseline heart rate at the time of the measurement. So as you know, your QT interval will shorten as your heart rate increases. This is a normal physiological response to allow the action potential to reset more quickly, allowing more rapid depolarizations. And there are a number of often very well-known formula for correcting the QT4 heart rate. The most commonly used is Bazit's formula. So this is the QT divided by the square root of the preceding R to R interval. Friederich's formula is very similar, but it's the cube root of the previous RR interval. But what this graph shows is that if you choose a corrected QT interval, very normal, in this example 420 milliseconds, you'll see that these formulae will give you a very different absolute QT interval over a wide range of heart rates. So while they are useful, they're most useful when clustered around a heart rate of 60 beats per minute. In very bradycardic or tachycardic patients, the correction is less accurate, leading to either an overestimate or underestimate of the true QT interval. So once you've actually measured your patient's QT interval, what you need to know is whether that's long or too long. I've always used to show this photograph of Alex Ferguson. He's a former manager of Manchester United, and was renowned for pressurising the referee to add in extra time at the end of a game, which was called Fergie time. Perhaps now he's retired and this chap's come along. This season, Liverpool were renowned for scoring late goals, so Fergie time has now been replaced by Kloppage time. But back to QTs. As mentioned before, there is a wide range in the what is considered normal for a QT interval, both in the general population, demonstrated by these two curves here, for males in the uninterrupted black line and females in the dotted line, and in those with genetically confirmed long QT syndrome. And you'll notice that there's a large overlap zone here where patients who are either within the normal population or long QT population may sit. Accepted normal upper limits is 450 seconds for a male or 460 milliseconds for a female, but it must be noted that simply falling slightly out of this range is not sufficient for a diagnosis of long QT syndrome, and other things must be taken into account, such as the patient's clinical presentation, changes on QT with exercise, and family and genetic background as well. Of course, in some cases it's much more obvious. This is another patient who presented, in fact, with a cardiac arrest and went on to be confirmed with long QT type 2. You'll see in this ECG that the QT interval is massively prolonged, measuring around 800 milliseconds with very bizarre looking T waves, and also shows a phenomenon best seen in these 3 beats of T wave alternans, where you have alternating high and low amplitude T waves, and this is a very high risk marker for impending arrhythmia. In general, the risk of arrhythmic events or syncope is low in most patients with long QT syndrome and is related both to their absolute QT prolongation and their underlying genotype. So we won't go into the genetics in too much detail, but suffice to say there are 3 subtypes of long QT denoted by the underlying genetic mutation, with 1 being most common, 3 being least common but highest risk. So moving from 1 to 2 to 3 increases your risk, as does an increase in your QT interval. In general, QTs under 500 milliseconds, particularly long QT type 1, have a low risk, and QTs over 500 is when the risk really starts to increase. In all cases, beta blockers, particularly the non-selective beta blockers, nadolol and propranolol, will reduce this risk and are recommended for all patients, apart from those who really definitely can't tolerate them, the numbers of which are actually relatively rare. This, coming back to our original patient, this is she was put on beta blockers and had a loop recorder fitted. This is a diagnostic device that automatically records any arrhythmias. She went back to France and we had this transmission several months later. So to orientate you, this is a single channel recording that starts here and runs consecutively through. So you'll see here, this is sinus rhythm. There is a ventricular ectopic here, and then a second one initiating torsade de pointe ventricular tachycardia. The device is to save battery, automatically suspend ECG recording when they have a sustained arrhythmia. So this was suspended for a further 48 seconds. And then when the device woke up again, patient was still in VT, and then miraculously perhaps reverted back to sinus rhythm. It transpired that she had forgotten to take her medication and gone swimming with a friend. And during this minute and 12 seconds of VT was being dragged out of the pool. And again, thankfully, he made a complete recovery. It's known that swimming is a particularly high risk in long QT1, and that's due to a combination of further QT prolongation at higher heart rates with the altered autonomic balance that's associated with breath holding and being underwater, and a subsequent increase in ventricular ectopy. So for those people who are dealing with long QT patients, counselling around exercise and swimming is particularly important. On to the next case. So this again is a young patient, 21-year-old chap who was resuscitated from a cardiac arrest. He'd been out to celebrate with a group of friends. He'd had a few drinks. He'd had a large meal and promptly collapsed on the dining table. And this was his ECG when he was brought into the emergency department after being resuscitated. So again, you'll see that this shows sinus rhythm. And the most striking abnormality in this case is the very bizarre looking QRS complex, particularly seen here in V1 and V2. He has conduction delay with an RSR pattern, or partial right bundle branch block pattern, associated with a very odd looking ST segment elevation and a negative T wave. I can tell you that this chap had normal coronary arteries, and this ECG is diagnostic of Brugada syndrome. So Brugada syndrome is another ion channel disease. It was first reported in 1992 by two cardiologists, Pedro and Josep Brugada, from just outside Barcelona in Spain. And they presented a case series of young men dying frequently in their sleep or being resuscitated from cardiac arrest in their sleep and having this unusual ECG pattern, which has since been coined the type 1 Brugada ECG pattern, diagnostic of this condition. So the type 1 pattern consists of a combination of an RSR pattern, particularly in the right ventricular leads, V1 and V2, followed by 2 millimeters or more of J point elevation. So the J point is the point between the end of the QRS complex and the following ST segment, and then coved or triangular-like ST segment elevation and subsequent T-wave inversion. And this is another example showing the type 1 ECG pattern in lead V1 and an associated similar but non-diagnostic pattern in V2. This is just to note that there are descriptions of type 2 and type 3 Brugada ECG patterns, which are suspicious of the condition but not diagnostic. And these are found probably in about 1 in 200 healthy individuals. And so it should be noted that if patients are not presenting with syncope, not to make a diagnosis of Brugada syndrome based just on a type 2 pattern, although it may warrant further investigation. Further notes on the ECG. It's known that in Brugada syndrome, the underlying electrophysiological abnormalities are in the right ventricular outflow tract, hence seeing the ECG abnormalities in V1 and V2. However, the RVOT sometimes sits quite high in a patient's chest, and so the standard ECG positions in the fourth intercostal space, V1 and V2, may miss the RVOT because it's sitting higher up. And therefore, we recommend, in addition, doing ECGs with V1 and V2 displaced into the second intercostal space in addition. This can be done very simply by moving your V3 and V4 electrodes into the second intercostal space, so essentially to stack them up above your V1 and V2. And this is an example of a patient where in their standard right ventricular precordial leads, there's a slightly unusual but non-diagnostic ST segment. But with the lead higher up, you can see a classical coved ST elevation diagnostic of Brugada syndrome. The further complicating issue around Brugada syndrome is that the ECG phenotype or the ECG manifestations can be highly variable. These are two recordings taken from a single 24-hour Holter monitor with the ECG's position in V1 and V2, but also in the second intercostal space again. And you can see that at 1:30 p.m. this patient has a type 1 pattern seen throughout all ECG leads, whereas later on in the evening, the ECG is less prominent, with the standard ECGs being non-diagnostic and maybe a borderline pattern in V1. So a single non-diagnostic ECG unfortunately cannot exclude Brugada syndrome, particularly in a patient where you think there is a high risk, either because of a clinical event or because of a family history of Brugada syndrome. And so to get around this variability, a diagnostic test called a sodium channel blocker provocation was developed. This involves giving intravenous sodium channel blocker. We use Ajmaline in the UK. Other places around the world would use flecainide or procainamide. And the idea is that if patients with Brugada syndrome and a non-diagnostic ECG are challenged with this sodium channel blocker, they will develop the diagnostic ECG pattern. This is an example from our clinic. So again, this ECG is orientated with the V1 and V2, and then the V3 and V4 electrodes are positioned in the high, so second intercostal space. So this is V1 and V2. And then after administration of the ajmaline, hopefully you can see here that the ECG is remarkably different, and we now have a diagnostic Brugada pattern seen in the standard and in the high RV lead positions. This ECG was taken from the first degree relative of the index case with the cardiac arrest. The risk of cardiac arrest in patients with Brugada syndrome, again, is very variable, similar to in long QT syndrome, although we don't have quite good such models for those who are high risk in Brugada syndrome, and we don't have any good medical therapy. The only real intervention available is either an implantable defibrillator or, in very extreme cases, a catheter ablation of the right ventricular outflow tract. This graph is here to show how different the rates of sudden cardiac death can be. This is taken from a population of Europeans with an average age of 45, and these red lines are the rates of sudden cardiac death compared to the average rate of death from all causes in the UK grouped by age. So you can see that if you have a drug-induced ECG but no symptoms, your risk of death goes from being a 45-year-old to a 55-year-old, nothing that we would be particularly concerned about. If you have an abnormal ECG but no symptoms, then you have the same risk of death as someone in their late 60s. But if you've had syncope or a cardiac arrest with either a drug-induced or a spontaneous ECG, all of a sudden you're at the same risk of dying as an individual in their 80s or even older. And when you're 45, that's a relatively big increase. And so those patients will almost automatically be offered an ICD. So that can also be shown in this simple 2x2 chart. Patients with an abnormal ECG and syncope should be offered an ICD, as should those patients with arrhythmic syncope and a positive sodium channel blocker test. Conversely, those patients who have no symptoms and simply have a drug-induced ECG pattern have been shown to be at low risk and do not require an ICD. And the group in the middle, so the abnormal ECG but no symptoms, are those patients where we unfortunately scratch our heads somewhat and maybe consider further assessment, which may be with invasive EP studies or additional monitoring. In terms of long-term follow-up, it's quite clear when people transition from the asymptomatic to symptomatic stage, but what's not known is how often patients fluctuate from having an abnormal resting ECG to having a normal ECG, and this can be a challenge for the long-term follow-up of Brugada patients. Okay, so moving on now to the next case. So this was a 28-year-old man. He was a regular athlete, often running marathons. He became unwell early on during a short 5-kilometer race. He didn't collapse, but he reported to the race officials feeling very unwell. A paramedic found him to be in this broad complex tachycardia with a heart rate of 200 beats per minute and a relatively low blood pressure. And so this, as I said, shows a broad complex tachycardia. And this is ventricular tachycardia. I won't go through in too much detail, but you can see little notches every so often on the QRS, and these are independent P waves showing there is dissociation between the atrium and ventricles, with more ventricular beats than there are atrial beats, meaning this can only be VT. For those ECG aficionados in the audience, this has a left bundle branch type morphology, suggesting it's coming from the right ventricle, and it has a positive axis in the inferior lead, suggesting it's coming from relatively high up, perhaps in the right ventricular outflow tract. He was cardioverted, and this was his sinus rhythm ECG during his admission, so not immediately afterwards, but several hours later. And now you can see sinus rhythm, so P wave followed by QRS. And again, looking at the precordial leads, there is a slightly unusual QRS complex with some fragmentation within it in V1, followed by inverted T waves that extend from V1 right out to V4, V5, and some ST depression in V6. He also had normal coronary arteries, and this gentleman has arrhythmogenic cardiomyopathy as diagnosed on his MRI scan. So these are cross-sections from an MRI in long and short axis. So in these top two images, you can see the interventricular septum here. The left ventricle is inferiorly here with the mitral valve. And then this is the right ventricle, the tricuspid valve would sit across here. And these are in diastole and then in systole. So the first striking thing is the right ventricle is very large, would normally be smaller than the left ventricle, but in this case is very much bigger. And during systole, you see this crenulation or irregularity in the outside wall of the RV, and this outpouching or relative dyskinesia. Similarly, again here in the short axis view, so this is the left ventricle here, interventricular septum, and the right ventricle, which wraps around the left ventricle, again extremely enlarged, and then these abnormal outpouchings in the lateral wall, which is diagnostic of arrhythmogenic cardiomyopathy, previously called arrhythmogenic right ventricular dysplasia, because it does predominantly affect the right ventricle, as in this case, although similar findings can be found in the left ventricle as well. So ARVC is caused by underlying problems in the cardiac desmosome. This is the structure that attaches cardiomyocytes to one another, and genetic mutations in these various proteins such as plakophilin and desmocollin causes this desmosome to fail, and the cardiomyocytes are stretched apart. The gap in between is filled with fat and fibrosis, and leads to structural weakening, but also an impairment of the electrical conduction through the ventricle, allowing these reentrant ventricular arrhythmias to occur. Other ECG features not present in our case are more gross manifestations of the conduction delay. So the pathognomic feature is this thing called an epsilon wave. So this is a blown up version of a V1 with an inverted P wave here. This is the QRS complex with an RSR pattern. And then after the QRS, a second discrete high frequency depolarization, which is an epsilon wave. It can also be detected by the signal average ECG, where you see a late and high frequency spike here. And this is a manifestation of that delayed conduction through the right ventricle. The formal diagnosis of ARVC can be complex. It takes into account ECG and imaging findings, as well as symptoms and genetic and family background as well. The treatment of ARVC involves antiarrhythmic medication, ICD implants, but particularly the restriction of individuals from participating in competitive sports, because that's known to exacerbate the condition. So that's covered a number of these conditions. I didn't go through CPVT or dilated cardiomyopathy because they don't really have diagnostic features, at least on the resting ECG. What I'd like to just do to finish off is to quickly go through bradyarrhythmias. So obviously these are not causes of sudden cardiac death through ventricular fibrillation, but patients can get asystolic cardiac arrests, and they're much more commonly seen in the emergency departments. So this is an example of complete heart block. So what we see here is a regular and slow ventricular rhythm, which is completely dissociated from the underlying atrial rhythm. So you have P waves that march through at a slightly irregular rate and have no connection to the QRS complexes. In this particular case, the QRS complexes are narrow, suggesting that the escape beat is coming from within the His-Purkinje system, and it's not so slow that the patient will require a temporary pacing wire. So in this case, it's a fairly low risk complete heart block, but even in these patients left untreated, obviously there is a risk of asystole and sudden death, and they should have a pacemaker implanted. Similarly, this is a 2-to-1 AV block. So you can see here highlighted by the stars, you have a non-conducted P wave in between each conducted P wave. So on the rhythm strip here, you have P, QRS, there's a second P in the end of the T wave here, which is not conducted, and then the subsequent P wave is conducted, and that pattern repeats through. So again, these patients have a high risk of progressing to complete heart block and therefore asystolic arrest, and should also get a pacemaker in almost all circumstances. Less worrying complete heart block involves type 1 AV block, which is just a prolonged PR interval. So in this case, a PR interval around 400 milliseconds. Or this, which is Wenke-Bach. So here you see a non-conducted P wave followed by a PR interval that is relatively normal and then subsequently prolongs over several beats before being blocked again, and the subsequent P wave being conducted with a relatively normal PR that then begins to prolong once again. So this cycle of progressive PR prolongation followed by a drop P wave is called Mobitz type 1 AV block or Wenke-Bach. This can be physiological, particularly in young healthy individuals, and is not a class 1 indication for pacing. However, in patients who have syncope, and particularly have this pattern of Wenke-Bach during waking hours and when they're ambulant, may also require a pacemaker, although the risk of sudden death is extremely low in these patients. And then finally, an example of a sinus rhythm ECG that carries a high risk of complete heart block. So this shows sinus rhythm. There's a combination of first degree AV block with a mildly prolonged PR interval. There is left anterior hemiblock, manifests as left axis deviation, and right bundle branch block, seen here in lead V1. So this combination of first degree heart block, left anterior hemiblock, and right bundle branch block is referred to as trifascicular block. Particularly important to note in patients who have presented with syncope, because it can progress to complete heart block, which is in fact demonstrated on this ECG. So you'll see at the end of the recording, the final P wave, which appears to come in slightly early, is not conducted, and then the patient has a ventricular paced beat. This ECG was recorded on the coronary care unit on a patient who presented with syncope and had a temporary pacing wire implanted just minutes before this ECG. So thank you very much for your attention. That was a kind of whistle-stop tour through some of the conditions that can cause sudden cardiac arrest, and I'd be happy to take any questions.
Well, thank you very much, Greg. That was fantastic as an overview for some really interesting ECGs and presentations that I'm sure we all see, albeit infrequently sometimes, but important ones not to miss. Can I perhaps start by asking you, Greg, about a very common occurrence we see on the ward? So I did a ward round earlier today, and on it was a young man who was walking his dog and felt a bit funny and then collapsed to the floor. Was unrousable for a few seconds, but is now in hospital. ECG looks normal, his blood tests are normal, his monitoring overnight is normal. I probably end up getting an echo, an outpatient ECG, 24-hour monitor, which is completely useless mostly, if I'm honest. Often it just says it's normal. Would I be better referring these people up for an ILR, or just saying, well, actually, it's probably just a faint, don't worry, go home and don't worry about it, sort of thing?
So probably the second option, I'll say, for us. So in terms of assessing syncope, it's worth noting that 40% of people will have at least one syncopal episode during their lifetime, and the vast majority of these are vasovagal in etiology. Normally, vasovagal syncope is fairly easy to identify from the history. So if patients have a stereotypical trigger, either they've just stood up or they've been stood up for some time, they have a typical prodrome and recovery that all sounds like vasovagal syncope, then the etiology is likely to be that. And if you look at the long-term survival of patients with syncope of that description, it's the same as people who've never had syncope. So the important thing is to note those people with arrhythmic syncope, so patients who have little or no prodrome, who are exercising when they have their syncope, or who have abnormal resting ECGs. And those patients probably require further evaluation. A syncope or a T-lock clinic, as you have at Addenbrooke's, is a good way to integrate cardiology and neurology to get the relative investigations. In terms of ILR, so implantable loop recorders, I would reserve that for somebody who had either 2 syncopal events which had some borderline features, or where you were suspicious of a particular diagnosis.
Okay, thank you. Dr. Borokar, do you want to take the next question? Yeah.
We've got some good questions come up, and this is a question from Amit. What he wants to know is, we have some of the genetically induced left ventricular hypertrophy. How do you distinguish that between HCM and LVH and a simple LVH, apart from the presentation age? Are there any other ways to distinguish between them?
So it's an excellent question and can be a real challenge. So the common scenario is a patient with high blood pressure, maybe a little bit older, who presents with left ventricular hypertrophy, and the question is whether it's hypertension or hypertensive heart disease versus hypertrophic cardiomyopathy. There isn't an easy way to know for certain. I think the important things to think about with those sorts of patients is there a family history of hypertrophic cardiomyopathy, or other people, members of the family who've died suddenly, where you may be concerned about hypertrophic cardiomyopathy? Is there truly a history of untreated hypertension to a degree that would be causative of the LVH? And then so some MRI features can also be helpful. The presence of late gadolinium indicating scar is much more common in genetically mediated or sarcomeric HCM than it is in hypertensive heart disease. But there are definitely some patients where you can't really tell, and certainly we have a number of those under long-term surveillance in our clinic.
Are there any ECG markers for cholinergic, catecholaminergic polymorphic VTAC? Can we diagnose that in the resting condition, because that's another area where you could get sudden cardiac death? Yeah.
So for CPVT, the resting ECG will be absolutely normal. So there are no diagnostic markers on the resting ECG. However, it is worth noting that if you have particularly a young patient who has presented with true arrhythmic syncope on exercise, CPVT should always be considered. It's a rare disease, probably at 1 in 10,000, but it has a very high mortality rate. The way of diagnosing CPVT is with an exercise test or an adrenaline provocation test, but preferably an exercise test. And what you're looking for is the induction of bidirectional VT on an exercise test. So that's the classic diagnostic finding. However, what you do often find, rather than the classic bidirectional VT, is just an increasing number, an increasing complexity of PVCs or ventricular ectopics as a patient exercises.
Rez?
Okay, thanks, Greg. You touched upon QT prolongation. Could you talk a bit about drugs that cause QT prolongation? Of course, there's been a question specifically about the dangers of hydroxychloroquine causing QT prolongation. So just perhaps a quick few words on drugs that might do that.
Sure. So it's certainly recognised that many drugs can cause QT prolongation. And often those individuals who have drug-induced long QT syndrome will have some form of genetic susceptibility underlying that. There is a very good reference website which patients can visit. There's also an associated smartphone app. It's called Credible Meds, so CREDIBLE meds.org. And that is run by a very reputable group and updated regularly. And that has a good reference list for which drugs should be avoided in patients with long QT syndrome. In terms of hydroxychloroquine, that is on that list. And even before COVID, it was recognised that hydroxychloroquine could prolong the QT interval. And obviously, there was a lot of media attention around this. Actually, there haven't been many cases of hydroxychloroquine inducing torsade de pointes, and that was the message from the rheumatologists who were using this drug regularly beforehand. Probably in terms of COVID, the concern was a combination of hydroxychloroquine and azithromycin, which was used early on. Of course, now the efficacy of hydroxychloroquine for COVID has been effectively disproven, so I think hopefully going forward it will be less of an issue.
Sure. Okay. And can I ask you another question in terms of sort of Brugada? I mean, we've had a question about how we treat people with Brugada. I mean, it's sort of slightly outside the scope of this talk, but perhaps you could just say a line or two about that. And the second question was more an observation. We found that people with cocaine use often have a Brugada-like pattern when they present after a binge of cocaine. Does that mean the cocaine has unmasked a Brugada condition underlying it, or is it actually just the effect of the cocaine per se?
So to answer the second one first, similarly to long QT, there are a number of drugs that are known to exacerbate Brugada syndrome, and cocaine is one of them. Whether those patients have, again, some underlying sensation towards Brugada-like ECG abnormalities, I don't know. But certainly cocaine has very significant effects on the heart. So I would be reluctant to diagnose somebody with Brugada syndrome who only ever had a Brugada ECG with cocaine use.
Sure. Well, I mean, it's a sodium channel blocker, of course, so it can cause a channelopathy in effect, like in Brugada. Yeah. And then in the first question in terms of the management of Brugada, so as I said, it's kind of maybe beyond the scope. In general, the key to management is the risk assessment. So many patients with Brugada syndrome don't need any specific medical intervention. They should be advised to avoid those drugs which can exacerbate the condition. We advise patients to treat any high temperature aggressively, because fever can be a precipitant for an abnormal ECG and a cardiac event. For those who are moderate or high risk of cardiac arrest, we may recommend a primary prevention ICD, but obviously that's a big question, often in a patient in their 20s or 30s. And then finally, for those truly high risk patients, often who have an ICD and who've received appropriate therapy more than once, there is emerging evidence that catheter ablation, where you essentially burn the epicardial surface of the RVOT, can have a dramatic benefit. But that's a big procedure with significant risks, and so therefore at this stage, unless the evidence improves, is reserved for the truly high-risk patients.
Before we just move on to Joseph again, I just one last quick question. And this is from Dr. Kiran. What's your choice in a pre-excited AFib? Would you like to do an unsynchronized or synchronized cardioversion?
So I didn't quite...
In a pre-excited AFib,
yeah,
would you prefer to do an unsynchronized or a synchronized cardioversion?
I think the synchronized cardioversion would be preferable, but I mean, yeah, it's often a fairly emergent situation, but you want to avoid the risk of an R-on-T phenomenon, so synchronized, yeah.
Okay, thank you so much, Greg. That was wonderful. We'll move on then to the final talk today, and I'll hand over to Dr. Cherry and Dr. Calvert.
Yeah. So our next speaker is Dr. Patrick Calvert, who is a consultant cardiologist who specializes in coronary and structural intervention. So we might need Patrick to tell us what that's about. But Patrick trained in Cambridge and Oxford, which also is quite an achievement considering we're technically enemies. So over to Patrick. Thank you.
Joseph, thank you very much indeed for that kind introduction. I don't know how well hopefully you can all hear me online. If you just let me know if you cannot hear me. So thank you very much, first of all, for the invitation to speak today. I've been asked to talk about the management of acute coronary syndrome. I've been asked to keep this suitable for the generalist and to focus on a case-based approach. So I've removed all the dry slides about data, and I've tried to keep it as clinically relevant as possible. I know for the audience it's getting late, and you're probably sitting down with your Saturday evening meal. And for us in the UK, that's almost certainly going to be a curry, because that's our beloved dish here in the UK. So think about that whilst you're filling your stomach with that fat-laden food. So if I can, here we go. So I think it's important, first of all, to define an acute coronary syndrome. There have been many changes of titles of myocardial infarction, acute coronary syndrome, etc. over the past 15 years, and this relates really to new diagnostic tests coming on. However, we have settled into a fairly stable pattern, and I'll describe those to you first. Next, we will go through how do I recognise an ACS in my clinical practice. We will talk about the management of an ACS, immediate and longer term, and then we will run through a number of clinical cases, all of which have come from my own clinical practice in the last 3 weeks. Joseph, you're asking what a coronary and structural intervention is. So coronary, I hope, is self-explanatory. I probably spend 70% of my time on blocking coronary arteries, mostly for acute coronary syndrome, although a small portion is for stable angina. Structural intervention is keyhole procedures to the heart. That means our surgeons don't have to open the chest, and that is expanding with treatment of holes in the heart, valve treatments as well. But that's for another day. So definition of acute coronary syndrome versus myocardial infarction. So I think the first thing to say, there's a great overlap between the two. But if I start by nailing down a myocardial infarction, and this is based upon the internationally agreed, and I would say simplified universal definition of a myocardial infarction, it is defined as acute myocardial injury, which is a rise and or fall in a troponin level greater than 99th above the centile of the upper reference limit. So there must be some injury. And in addition, you need to have either symptoms consistent with myocardial ischemia or new ischemic changes in ECG. And that will give you a diagnosis of a myocardial infarction. There are some other types of diagnoses, which I'll not go into because they're not clinically relevant. Type 1 myocardial infarction is due to a plaque rupture of an atherosclerotic plaque in a coronary artery, and this results in either intermittent coronary artery occlusion or complete coronary artery occlusion, and that is termed a type 1 myocardial infarction, and that is responsible, I would say, for around about 90% of myocardial infarctions. There is a type 2 myocardial infarction, which is not due to a plaque rupture or a vessel occlusion. Rather, it is due to an imbalance between the demand for oxygen and the ability of the heart to supply it to the heart tissue. This is typically or most commonly caused by atrial fibrillation, whereby a patient may have some underlying coronary stenosis that are quite stable and are not going to block the vessel. And if you suddenly put upon that a heart rate of 170 beats per minute, then you have a supply demand, and often you'll get a troponin leakage with that. Less common is coronary artery spasm, and rarely it can be a cause of quite high troponin rises, but that is unusual. So if that's what the definition of a myocardial infarction is, then what is a definition of an acute coronary syndrome? Well, I'd like you to think of it this way. An acute coronary syndrome is the working diagnosis that allows you to treat the patient. Of course, the confirmation of an acute coronary syndrome being a myocardial infarction comes when you have the evidence of myocardial necrosis, which is when the troponin comes back. And that only comes back, although we have some rapid assays these days, it is not usually at the time of first assessment of the patient. It may be hours, maybe a short number of hours, but it's certainly later. If you add into that also, there are a group of patients who have clear symptoms suggestive of myocardial ischemia or ECG, but for some reason the the ischemia has not been enough to result in myocardial infarction, and therefore the troponin is negative. These have often in the past been termed as unstable angina or crescendo angina. And I would say to you that in this day of increasing sensitivity of biomarker tests such as troponin, this is becoming a rarer and rarer breed. So myocardial necrosis is usually present. And in the vast majority of cases, ACS and myocardial infarction are the same thing. So I have alluded to this already. If you look at this schematic here, on the left-hand side is a schematic of a coronary artery, a cross-section. You can see the white area is the lumen where the blood runs. And here we have a lipid-laden plaque that's got a thick cap overlying it. This is the origin of stable angina. Of course, this narrowing wouldn't be bad enough to cause stable angina. And you get a supply and demand ischemic effect, i.e. when you exert yourself, you get some angina and it goes away. And funnily enough, the progression from stable to unstable angina or myocardial infarction is at rather low level. It's in the single figures per annum. If you look at the histological specimen on the top right, this is a histological specimen of a patient who had stable angina and an atherosclerotic plaque. You can see the lumen is here, where I hope you can see my arrow. This is the outer wall of the coronary artery, and you can clearly see the lipid-laden plaque here and a very thick, very stable cap. This is very unlikely to transform into an unstable plaque. This is unlike the histological slide below, which is a cross-section through a patient who in fact died from myocardial infarction. And what you see here is the lumen, and this is a very thin plaque that's ruptured, and in fact this dark material is blood that's bled into it, and this patient died from a myocardial infarction. And the representation is seen here in the slides with clot. Once the atherosclerotic material is leached out of the atherosclerotic plaque, it's highly thrombogenic, and you get a clotting cascade of platelets and fibrin, and this rapidly causes either near occlusion or occlusion of the coronary artery, which is responsible for almost all acute coronary syndromes. I would just add that intimal erosions is also a cause of it, but a much smaller cause. So, how do I recognize acute coronary syndrome in my clinical practice? Well, let's start with symptoms. And if I just run through this is from an audit of our work, and it is approximation, but chest pain is very common in patients with acute coronary syndrome. It isn't universal, and there are particular groups who tend to have less clear chest pain than others, which I can go through if the audience are interested. It's typically described as a central tightness or weight or pressure. It can radiate down the arms, left arm in 48%, right arm in a much smaller proportion, and up to the neck in around 1 in 5. It's often associated with shortness of breath, even in the absence of any obvious pulmonary edema. And I think these two symptoms are very important: nausea and sweating and clammy. The term is used as diaphoresis. Patients have an autonomic drive. They feel unwell with it. And in those patients who don't have chest pain, they almost always have another clue. They almost feel sweaty, clammy, and often look pale. The chest pain should last more than 10 minutes, and diagnostically speaking, that's a fairly good cutoff. But it is important to point out it can be a difficult diagnosis, and you must have a high level of suspicion. If we move now to the clinical examination, well, the most common clinical findings are nothing, i.e. it's an unremarkable clinical examination. I have alluded to already to the fact these patients may be sweaty and clammy. A careful respiratory and cardiovascular examination are, of course, important to look for clinical manifestation of cardiogenic shock, slow heart rate, rapid heart rate, but also to listen to the heart for any major valve issues, which can be a consequence of a myocardial infarction, or indeed a hole in the heart as a consequence of myocardial infarction, both of which, by the way, are very serious and catastrophic complications of myocardial infarction, and tend to occur when there isn't a rapid and early treatment. And interestingly, in the United Kingdom, where we're fortunate to have a very well-developed heart attack centre where basically all ST elevation acute coronary syndrome are referred rapidly for immediate primary PCI. In this COVID period, we've noted an increase in these major complications where there seems to be more delays than we've had in the past in patients presenting with heart attacks. Of course, pulmonary edema can be a presentation as well. So therefore, the oxygen saturations must be measured. It can be difficult again, and there must be a high level of suspicion. Thirdly, the electrocardiogram is absolutely fundamental to determining the management of the patients with acute coronary syndrome. If the electrocardiogram shows elevation of the ST segments, that's the segment just after the QRS, and if there is elevation in 2 adjacent leads of more than 2 millimeters in the chest leads, or in 2 adjacent leads of more than 1 millimeter in the limb leads, this qualifies as an ST elevation acute coronary syndrome, or ST elevation MI, and this patient needs immediate revascularization. This patient has a blocked vessel, there's ongoing myocardial death, and the death will be complete within 12 hours, and actually much of the damage is done in the first few hours. And the ability to open this artery early will have a long and lasting mortality benefit on this patient. Everything else qualifies as a non-ST elevation acute coronary syndrome. That might be T-wave inversion, it might be ST depression, and those two are the findings on an electrocardiogram that are just typically associated with a non-ST elevation acute coronary syndrome. If you will, there tends to be a clot that is forming and being broken down by the body, therefore this intermittent occlusion of the coronary artery. But I have to be clear that the most common finding on an ECG is no obvious change. This is an electrocardiogram of a patient with an ST elevation acute coronary syndrome. I think Greg's taken you through ECGs, but just very briefly, electrocardiograms tend to have a rhythm strip along the bottom, which is important to look at. It's usually lead 2, which is one of the limb leads. You can see there's a P wave followed by QRS, so this is sinus rhythm. If we then look at the QRS duration, well, in fact, it is normal here. And then what you do see in this patient, there's quite pronounced Q waves already, giving us a suggestion that this myocardial infarction may, in fact, already indeed be complete. The bit that comes after the QRS is the ST segment, and you can see across the chest leads, which are leads V1 to V6, there's clear ST elevation in these segments, 5 to 6 millimeters, and therefore this means that there's been necrosis in this area and tissue death. And you can see also in the lateral leads and then reciprocal depression. And this, to me, would be a patient who's had a myocardial infarction and I'm afraid has probably not been offered revascularization, and would be associated with quite a high mortality rate. So an ST elevation acute coronary syndrome, as I said, suggests ongoing myocardial death. It's a blocked artery and they need referral for immediate revascularization, provided that the patient's been identified within 12 hours of onset of chest pain. Do bear in mind, however, chest pain can often come and go. And if a patient's outside 12 hours, I often ask them, well, when was the worst pain? Because the pain can often fluctuate. You will often get stuttering pain before the artery blocks completely. For non-ST elevation acute coronary syndromes, I've described the typical changes already. This represents, I've written myocardial ischemia, but actually more accurately, it's usually intermittent infarction is what it generally is. The myocardium is threatened, but there's a great ability to salvage. And if there are high risk features, ECG changes and elevated troponin, and of course, very typical symptoms, invasive angiography and angioplasty and stenting is recommended within 24 hours through the ESC guidelines, otherwise within 72 hours. This is a typical ECG of a patient with a non-ST elevation acute coronary syndrome. And you can see across the chest leads here, there's deep T-wave inversion. This is typical of a patient who has a clot in the left anterior descending artery. And this ECG tells you that this patient has a lot to lose if they don't get on and have the PCI treatment quite quickly. I thought I'd show you this ECG as well because it's a cause of a lot of concern in patients that are referred to us. According to the current international guidelines, new left bundle branch block in the setting of a patient who has symptoms consistent with myocardial ischemia is an indication for primary PCI. That is immediate transfer to a heart attack center to have angioplasty and stenting. It's a cause of great frustration for those like myself who open coronary arteries because in most patients, the left bundle branch block is either not new or is not a sign of a myocardial infarction. Rather, it's due to some conduction tissue disease. what I would say is those patients who do have left bundle branch block and who are having a myocardial infarction, they almost always also have ST elevation, and they tend to be extremely sick, by which I mean it is not a subtle clinical diagnosis. I think this is quite a good schematic to summarize what we've talked about already. The term acute coronary syndrome will give you a working diagnosis. Remember, we've talked about typical symptoms of myocardial ischemia and an ECG. That gives you the diagnosis of acute coronary syndrome. And then this is later confirmed whether it is a myocardial infarction or not with our biochemical markers. And you've already seen the two histological definitions on the left. Consistent with a non-ST elevation ECG, we have a ruptured plaque, but it's not completely occluding the vessel seen on the left-hand side here. On the right-hand side, the plaque is also ruptured, but the whole vessel is occluded. And finally, before we move to the clinical cases, this is a summary, and I think this is quite a useful summary. If we talk, it talks about probabilities in likelihood, and I think it's a really nice way of summarizing it. The more you go from the left side to the right side, the higher the likelihood of this being a high-risk ACS, and the higher the likelihood of this needing urgent treatment. If we start with presentation, if there's a low likelihood, then it's a low likelihood on clinical presentation, then you have a lower degree of suspicion. If you have a normal ECG on the left-hand side, passing through to T-wave inversion and ST depression with culminating in ST elevation, the likelihood and the severity gets much more. And when troponin is available, as it often isn't at immediate presentation, the higher it is, the more certainty with the diagnosis. And so you have a spectrum between non-cardiac chest pain, the so-called unstable angina term, or perhaps other cardiac causes, and then high-risk non-ST elevation MIs or ACSs, and finally ST elevation ACSs or MIs. So what about the management of acute coronary syndrome? Well, I think what I'd like to emphasize on you, we all have busy clinical practices. These patients need immediate and priority assessment and treatment. And the priority is to deliver revascularization as soon as possible. And that revascularization, evidence-based, is balloon angioplasty and stent. I've already said key to the management is the ECG for ST elevation ACS. There must be immediate referral to a heart attack center for immediate primary PCI, and this is only beneficial within 12 hours of onset of chest pain. For other high-risk features in a non-ST elevation ACS, PCI within 24 hours, and for other ACS, 72 hours. And this is all based upon evidence-based guideline from the ECS. I would like to remind you, though, that these patients are at a high risk of cardiac arrest, and I'm not going to go through the diagram on the right-hand side, but just to remind you, the staff who look after these patients must be fully versed in advanced life support because there is a higher risk than in most patients of cardiac arrest. They need to have cardiac monitors. They need to have their oxygen saturation monitored, and they need to have IV access and appropriately trained nursing cares and environments. All ACSs should have a opiate pain relief, although only give it if they're clearly in pain. Correction of hypoxia with oxygen. Nitrates provide symptomatic relief, but I have to be honest, little else. Fundamental is the antiplatelet loading. And all patients in this country, the United Kingdom, get 300 milligrams of aspirin. They should also receive either one of the others in addition, which is either clopidogrel 600 milligrams or prasugrel 60 milligrams or ticagrelor 180 milligrams. And a very interesting large trials recently published in the last couple of months that suggests that that prasugrel may be superior to ticagrelor, and the latter two are superior to clopidogrel. I'm not going to go through this diagram. I've shown it simply to illustrate the importance of the platelet and the clotting cascade in the treatment of acute coronary syndrome. This is the efforts that have been gone to modify this process. And all of these drugs have a role in some place in this. What if there is no heart attack centre, a primary PCI centre available? Well, there are some countries in Europe that are large, and in those situations, they have air helicopter transport. And there are a number of trials to show that it is better to helicopter transport someone within timescales than it is to provide thrombolysis. Thrombolysis has been shown to be more effective than other medical treatments in ST elevation myocardial infarction. It hasn't been used in the UK really for more than a decade now, because it has high major bleeding risk and it is much less effective than primary PCI. However, it is acknowledged that heart attack centres and networks are expensive and logistically hard to set up, and lysis is beneficial in the absence of adequate primary PCI centres. And I would say that lysis can be very effective in the first hour after chest pain. But in many regards, fibrinolysis alone is not enough. And although it can just about get the artery open, in many regards, there's a substantial myocardial injury afterwards, and they still need to go on to have PCI anyway. For non-ST elevation acute coronary syndrome, fondaparinux, which is a factor Xa inhibitor, is also indicated. It has similar beneficial effects and is less bleeding than enoxaparin. Glycoprotein 2B3A inhibitors are a very powerful class of drugs for antiplatelet inhibition, and were used a lot in the 90s and the noughties. They're really now only used as a prelude to PCI and in the cath lab itself, and they're associated with a high bleeding risk. Post-PCI management, these patient needs cardiac monitoring on a coronary care level of nursing support because of the arrhythmia risk. They have 1 year of dual antiplatelet therapy, beta blocker, ACE inhibitor, and statin. And in patients with impaired ventricular function, a pleuronone, which is an aldactone inhibitor, is associated with decreased arrhythmic death. Also important is cardiac rehabilitation with exercise classes, diet, lifestyle modification, and smoking cessation. And one of the benefits of primary PCI over fibrinolysis is that patients are usually discharged from hospital within 48 hours and have a much quicker rehabilitation and recovery. I'm mindful of the time that's late, but I would be keen to go through some clinical cases, which I'll do now. First clinical case is a 58-year-old gentleman presented to one of our local district general hospitals with chest pain. He had a 2-day history of intermittent chest pain, the longest lasting 20 minutes. His past history includes hypertension, high cholesterol, and he stopped smoking 10 years ago. His clinical examination was unremarkable except for elevated blood pressure. This is his ECG, and I have left. Most ECGs get written on by someone at some point, and I've left them on because they're almost invariably wrong or a distraction. So please don't put too much faith in either what your colleagues write on an ECG or indeed what the automatic machine writes. If we get down to the nitty gritty of this, you can see if you look at the chest leads, we have T-wave inversion lead V3, V4, and V5. And not much else to see really. So is this an acute coronary syndrome? Well, the questions we asked ourselves are the symptoms of myocardial ischemia? Are there ECG changes suggestive of myocardial ischemia injury? Is there a serum biomarker elevation suggestive of myocardial necrosis? And is this an ACS? Well, symptoms, yes. ECG changes, yes. Serum biomarkers, well, in this case, the serum biomarker came back elevated, and that's a significant elevation for our reference ranges. Top range of normal is around 40. Is this an ACS? Yes, it is a non-ST elevation ACS with anterolateral T-wave inversion. What is the management? The immediate management is cardiac monitor, aspirin 300 milligrams. In this country, we're often still giving clopidogrel 600 milligrams, although ticagrelor and prasugrel are probably slightly more effective. Morphine, because the patient had pain, fondaparinux, and transfer to a coronary care unit. For our heart attack network, this patient would be classified as a high-risk non-ST elevation ACS. We have a rapid ACS program, and these patients are transferred and treated within 24 hours. Post-PCI care, this patient received ticagrelor 90 milligrams BD for 1 year, aspirin 75 milligrams, atorvastatin 80, bisoprolol 2.5 and ramipril 2.5 milligrams, both of which will be up titrated by the GP, and cardiac rehabilitation. And I know this is not a talk about angiograms, but I can't resist to show you some. This is my bread and butter. This is a coronary guiding catheter in the left main stem, seen on the left-hand side. These arteries are the top of the circumflex artery, and this was this gentleman's left anterior descending artery supplying the anterior part of the heart. You can see a tight stenosis here and a critical stenosis here, and actually diminished flow down the artery. And after I've implanted 2 coronary stents, we've got no stenoses and normal flow. This is a tip of the coronary guide wire you can see here. So, second clinical case. This is a 72-year-old female presenting with a 1-hour history of chest pain, feeling unwell, fainting, nauseated, tightness in her chest and left arm. Past history includes high blood pressure and diabetes. On clinical examination, she's pale, she's sweaty, her oxygen saturations are normal, and her blood pressure is at the low end of normal. This is her 12-lead ECG. If we look at the rhythm strip here, you can see we have sinus rhythm. And interestingly, we have an atrial ectopic beat here. We next look at the QR duration. I would say it's slightly prolonged. You don't have the computer measurements. It looks like it's about 4 small squares. So there's a partial or a not particularly large left bundle branch block here. If we look at the ST segments across the chest leads, I have to say I actually believe that lead V1 and V2 are the wrong way around here. So I think this should be V1. And there's minor ST depression here, but nothing much else across the chest leads. But if we look at the limb leads, now leads 2 and 3 in AVF, look at the inferior part of the heart, we can see clear ST segment elevation. And so this patient is having an ST elevation acute coronary syndrome. So we ask the same question, symptoms. Yes, we have symptoms of myocardial ischemia, and in fact, the symptoms are ongoing. Are there ECG changes suggestive of myocardial ischemia or injury? Yes, and it is ongoing as evidenced by the symptoms, but also the ST elevation on the ECG. Are there serum biomarker evidence of myocardial necrosis? Well, we don't know because it's not been done yet. Is this an ACS? Yes, it's an inferior ST elevation ACS. What's the immediate management? Well, cardiac monitor, aspirin 300 milligrams, clopidogrel 600 milligrams, morphine because of ongoing pain and oxygen. This is an inferior ST elevation ACS. Chest pain's been going on for 1 hour. This patient needs immediate transfer to the primary PCI center. These patients are not admitted to District General Hospital, and our ambulances will take these patients directly to the heart attack center rather than taking them to the nearest center. Post-PCI treatment, ticagrelor 90 milligrams BD, 1 year, aspirin 75 milligrams, atorvastatin 80, beta blocker, ramipril, and cardiac rehab. And this is the coronary angiogram. This is a case I did at 3 in the morning, which is often when these patients present. This is a right coronary guiding catheter. This thread of a vessel is not the right coronary. It's actually the conus branch. And this is the right coronary, remarkable by its absence. There's a thrombotic occlusion right at the start. And when I've fitted 2 coronary stents, you can see that the vessel has normal flow and has been restored, and the blood supply to a large part of the myocardium has been restored. As a matter of interest, whilst I'm opening the right coronary artery, I've opened it first with a balloon, and before I fit the stent, this happened. And if we reflect on what's happened, what is actually happening here? The heart rate's much slower. These are the inferior leads. First thing to note is that the ST segments have actually dropped. So we have, and the QRS rate is much slower. So we have P waves marching through, which are dissociated with the QRS. So this is complete heart block. So what has happened? Complete heart block as a consequence of a reperfusion injury. Funnily enough, patients often get quite unwell for about 10 to 20 minutes before they get better. What is the treatment? Atropine, 600 milligrams IV, and a temporary pacing wire if needed. But actually, very often, a temporary pacing wire is not needed, and they recover quite quickly. Clinical case 3, and if I have time, I'd like to do this case and one further case. We can keep them quite brief. This is a 49-year-old male presented to a local District General Hospital with chest pain. It was intermittent chest pain that occurred during the course of the day of presentation, longest 20 minutes. He has a history of ongoing smoking and a family history of a premature myocardial infarction. For our country, 52 years of age would be a premature myocardial infarction. Clinical examination showed no murmurs, normal oxygen saturation, and a slightly elevated blood pressure. This is a 12-lead ECG, which is faxed through by the District General and reviewed by my cardiology registrar. If we look at there is sinus rhythm with actually a tachycardia rate around about 90 beats per minute. If we look at the chest leads, he's quite a young gentleman and actually was quite thin. This peaked T wave seen here can be a sign of early ischemia, but it is quite common in young, thin males, and it's called high takeoff. So nothing particularly remarkable here necessarily, but good symptoms. So the patient was kept in. He's got symptoms. Is there evidence of myocardial ischemia or injury in the ECG? Well, probably, possibly. Nothing on the ECG that necessarily triggered an ST elevation or a primary PCI activation. So the patient was admitted to the local CCU. Serum biomarkers, well, they weren't initially available. Is this an ACS? Well, principally based upon the symptoms, yes, it's an ACS. So the patient was admitted to the CCU, cardiac monitor, and the usual medications as I've described twice already. Was he transferred to the ICS, primary heart attack center? Well, no, he wasn't, because we didn't feel it was ST elevation. He didn't trigger the criteria, and the post-PCI treatment would have been that. But 4.25 hours later, his ECG did this. He got more chest pain, and this is the ECG we received. Now, this is the same patient just 4 hours later. We can now see clear ST elevation of the segments across the chest leads. This patient is now having an anterior ST elevation myocardial infarction, and the situation is completely changed. He should now be activated for a primary PCI. He came to the cath lab, and this is a circumflex artery, but this is the left anterior descending artery, which supplies the front of the heart, and it's the largest myocardial artery, and it is blocked. And after 2 drug-eluting stents, you can see it's reopened. Final case, and I think this is a particularly interesting and challenging case. This is a 42-year-old female presenting with a 1-hour history of intermittent chest pain. She's feeling unwell, faint, nauseated, tightness in her chest. She has no past history of note. Her clinical examination by the time I came to see her was unremarkable. Blood pressure was a little low, not unusual in young females. And this was her initial electrocardiogram. So I have removed leads V4, 5, and 6 for a reason you'll understand in a minute. And they were relatively unremarkable. They look much like leads 1 and AVL, which are also laterally looking leads. This patient is in sinus rhythm. If you look at lead V1 and V2, there is a suspicion of ST depression in these leads with a dominant R wave. And actually, if you look in lead 2 as well, and AVL, and perhaps 3, there's also some minor ST elevation of almost a millimeter. This makes you wonder about the diagnosis of a posterior myocardial infarction or ST elevation ACS, but of course the posterior part of the heart is not well seen on a standard 12-lead electrocardiogram. So what you do in these situations, you put 3 further leads laterally around the heart, around the lateral aspect of the chest, and these are called leads V7, 8, and 9, and these look at the posterior part of the heart, and you can see clear ST elevation. And so are there symptoms of myocardial ischemia? Yes. Are there ECG changes of myocardial ischemia? Yes, they're ongoing. The biomarkers are not done yet, of course. This is a posterior ST elevation ACS. The immediate management, well, we've described this on a number of occasions. Transfer to a primary PCI center or heart attack center? Yes. Posterior ST elevation myocardial infarction with 1 hour duration of chest pain, immediate transfer to primary PCI center. And I'll come to the post-PCI management in a second. This was her coronary angiogram. This is particularly interesting. So this is the guiding catheter, which is sitting in the left mainstem. This is the left coronary artery. This is her LAD, which you'll see better in a minute. And the first pictures of this was relatively unremarkable. Her circumflex is highly abnormal. This was a dominant left circumflex. I think it's quite clear to see there is a line down the whole length of the circumflex. And this patient has had a spontaneous coronary artery dissection, which resulted in intermittent blockage of this vessel. I put a camera over a wire into her circumflex coronary artery called an IVUS camera, which is a 40 megahertz ultrasound camera in a radial phased array. And this gives you very fine detail of the coronary artery. You can see at this point in the coronary artery, this is a cross section of that artery. This circle is the camera. The black area is blood in the lumen. And I want you to look at the wall of the artery seen here. There is white, dark, white. The white is the intima, the dark is the media, and the outer white is the adventitia. This is completely normal architecture of the heart, of the coronary artery. And at this stage, indeed, the artery is normal. So there's no dissection here. If we look further up here, where of course the angiome is quite abnormal, we see a very unusual and very abnormal appearance. At this point in time, this camera is actually sitting in the false lumen. It's outside the true lumen. The wire has gone outside the true lumen, and this is all false lumen. And you can see here, this is normal architecture, and then the media is split in two, and it folds off and away. And so the true lumen, where blood supplies the capillaries, is folded right over and compressed. And then when we come further up, the camera is now in the true lumen, and you can clearly see the dissection flap here. And interestingly, not only can you see the dissection flap, but you can also see flow into a coronary artery, so into a branch artery. So there's a highly unusual appearance, and this patient, and what is also unusual about this patient, of course, they're a 42-year-old female with no other past history. And this often tends to occur in patients who are young and female, and they tend to have some form of underlying connective tissue disorder. When I put a wire down the circumflex and also down the left anterior descending artery to stabilize both, because the patient has a very short left main stem, of course, the left anterior artery started falling apart as well. This patient was extremely sick, and I was lucky enough to be able to rescue the situation with 2 stents of the left anterior descending artery, which interestingly also tacked up the dissection entry into the circumflex, and the patient made an excellent recovery. So I think it's probably time to conclude. Acute coronary syndrome is a potentially fatal but easily recognizable and treatable condition. I think the key is to have a high level of suspicion. Immediate assessment and treatment is key to saving lives, and the ECG is crucial to deciding what the immediate management will be, and confirmation comes from the biomarker level further down the line. For patients who have ST elevation on their ECG, they should have immediate invasive angiography and PCI, and those who have non-ST elevation ECGs, urgent PCI is a key to improve survival. Coronary artery bypass grafting or bypass surgery has no role in the management of ST elevation myocardial infarction. Surgeons will never operate in these patients in this country because it is a less good treatment and it cannot be delivered as quickly. In patients who have highly complex coronary anatomy, multi-vessel disease, and a non-ST elevation ECG, then coronary artery bypass surgery does have a role. Fibrinolysis can be effective in patients with ST elevation ACS in the appropriate times, but it is clearly, unfortunately, second to primary PCI, which is associated with better outcomes and quicker discharge from hospital. That's all I have at the minute. I'll pass back to the moderators for any comments.
Well, thank you so much, Patrick. That was a very clear talk, and I think the comments we're getting suggest that some of the audience are very happy with the talk, so thank you so much. We've got some interesting questions, so as a pharmacologist, I'm going to start with the pharmacology ones. I think you mentioned that you would recommend dual antiplatelet therapy for 12 months post-PCI. So Dr. Narendra asked how long you'd give antiplatelets after ACS. I presume he means with or without PCI, after the dual antiplatelet regime. And Dr. Kunigri asks, we know from data from the T trials that high-dose statins are now the form fruste of ACS management. So how long would you continue the high dose, and would you base it on LDLs or would you base it on their risk pattern?
So thanks, Joseph. So I'll take the first question. So the guideline mandated direction for all ACS in this country, whether whether there's a PCI or not, because of course not all lesions need to be stented, but that does tend to be what happens, is 12 months. There has been a lot of trial data on this in the last 10 years, and some of our transatlantic cousins in the States would recommend longer duration, but in the United Kingdom we go for 12 months. Interestingly, some of the French trials would suggest that shorter duration is also acceptable, and the European guidelines has generally come up with a bit of fudge. The standard is 1 year, but it should be tailored to the patient. So in a patient who's extremely high bleeding risk, a year is preferable. The complicating factor is that stents in the past had to have dual antiplatelet for 1 year, but stents are very much better than they used to be. And in some of our patients with high bleeding risk, we would be happy stopping the antiplatelets earlier, but of course a single antiplatelet needs to carry on further. The second question you asked is about the high dose statins. And you're quite right about the TIMI trials, TIMI trial, high dose of atorvastatin being superior to pravastatin. It is our workhorse. It's what we recommend. Joseph, I would probably defer to your knowledge on this about how long it should be carried on in the long run. I am not aware of any really good data to say that it should be carried on 5, 10, 15 years. And, the generalists have to see the patients who are getting all the muscle side effects, and young cardiologists who want to open every artery tend to insist patients carrying with atorvastatin 80 forever. But actually, once you get a bit old and realize that patients, and maybe when, Joseph, you need your statin yourself, you start to realize maybe they're not. So I try and let them take it for a year. I'm a bit more relaxed after a year. And the trial data, I'm not sure is totally clear how long it should be for. The low doses of statins have a very beneficial effect on the LDL cholesterol level, but of course are not proven to have mortality benefit. And really, there is something about statins that's above and beyond the LDL level. But I think probably, Joseph, you're probably more qualified than I am to talk about that.
Yeah. I mean, I think that it's an interesting area because we've got PCSK9 inhibitors and the siRNA molecules coming out, which are once or twice a year. So I think the state of play will change, and we need the evidence. You're right. I'm not aware of any trials as such that answer that question. Okay, Dr. Bobika?
Yeah, Patrick, thank you for that great talk. And in a 12-lead ECG, I think the AVR lead is the most ignored one. But when you find ST elevation in the AVR suggesting a left main disease, how comfortable are you with taking them for thrombolysis versus primary PCI? And this question is from Dr. Kiran.
I think the indication for primary PCI and the indication for thrombolysis on the electrocardiogram is the same. Okay, that's the first thing to say. Elevation in AVR in itself, in isolation, is not an indication for thrombolysis. One of the many benefits of having the luxury of being able to take patients to the cath lab is in patients who have ST elevation in AVR who usually have watershed ischemia, i.e. a type 2 myocardial infarction. They usually don't have a blocked vessel. What they usually have is critical coronary ischemia. Probably the last thing they need is thrombolysis. What they need is to be taken to the cath lab, and then they need bypass surgery. That is usually what those patients need. So I would not I would not give patient in the absence of a heart attack center and an early PCI or angiography. I would not recommend thrombolysis in isolated elevation in AVR.
And on the same lines, this is a question from Dr. Ravi. If you have a patient with a new left bundle branch block and you find that you don't have a cath lab nearby, would you then proceed on with a thrombolytic therapy for STEMI?
That's a really good question. For me, it would depend on how clear you are or how certain you are the patient is having a myocardial infarction. And of course, it is difficult, as I have said. I think you probably recognize that I'm a bit skeptical about left bundle branch block. My advice in that circumstance would be I would not thrombolyze someone who's got left bundle branch block in the absence of ST elevation. Okay? If there's a left bundle branch block and there's no ST elevation, I would not thrombolyze them. Therefore, I'm not fond of it as an isolated indication for either of those things. A patient who has left bundle branch block and who's having a myocardial infarction is a very sick patient.
Chirian, would you like to go ahead with the next one?
Sure. So Dr. Gaurav asked the question, which is interesting. So there's a difference between non-ST elevation MI and ST elevation MI in terms of risk. So could you go through that? And I think he also asked about thrombolysis, but of course thrombolysis we use for ST elevation. How is the management different for non-ST elevation, and when would you do a rescue PCI?
Okay, so there's a few questions in that. The risk of ST elevation and non-ST elevation is very complicated in this country, and I can only really talk of my own experience. For the past 5 years, the outcomes of patients who present with an ST elevation myocardial infarction have paradoxically been better than those patients with non-ST elevation MI or ACS. Now, the reasons are complicated. Don't be confused. An ST elevation is a high-risk entity. What happens in our country is these patients are immediately identified and are immediately referred to a cath lab, immediately see a consultant cardiologist and have immediate treatment. So as a result, they start in a bad place, but they end up in a good place. The problem with non-ST elevation is that they're harder to recognize and therefore they're less likely to get either quick treatment or in some cases treatment at all. And so we have this paradox in this country where less risky patients have worse outcomes. And we've tried to improve that in this country, at least in our region, by having a rapid non-ST elevation program, which we serve for our region and is starting to do well and has been helpful. So that's the first question. I think there was a question about rescue. When do you do rescue lysis? Look, I'm fully aware of the different geographical availability of heart attack centres, and I know they're not universally available across the globe. I think if you have a healthcare setup where that is the case and patients, and the default is thrombolysis up front for logistical reasons, then the quicker you can get them to a heart attack centre, the better. There's a lot of rather inconclusive data about rescue PCI, but I think the very least you can do is you're presenting them to a specialist centre where they have their arteries imaged. The actual benefit to opening up an artery is debatable, and it's usually because there's been such a delay in getting them there. Fibrinolysis is, it's not brilliantly effective. It is definitely better than doing nothing, but it is not that effective, and it is also associated with bleeding risks, quite significant bleeding risks. Joseph, I think there was a third question which I've missed.
Yeah, I think it was more to do with thrombolysis and the differences in treatments between non-ST and ST. What would you recommend as the best treatment for non-ST elevation? And also, I suppose, angioplasty post 6 hours.
Yeah, okay, so let's be clear. There is not an indication for fibrinolysis in patients who do not have ST elevation in their ECG. So let's be clear on that. Fibrinolysis is a potentially dangerous drug and should only be used in the correct people. If someone has fibrinolysis and then you can send them to a heart attack centre and they can have PCI within 6 hours, then you must do that. That would definitely be better. I would probably argue, and the evidence is a little bit equivocal on this, but you're probably actually better off just sending them to the PCI centre and them just having PCI. Probably that's what the data shows us.
Patrick, if you had a patient coming with typical chest pain, the ECG shows ST elevation MI, you don't know his COVID status, would you like to lyse him and look at his status and then take him up to the lab, or how do you want to do this?
Brilliant topical question, thank you. We thought a lot about this in the last few months, and we thought a lot about it, and we've got a very clear pathway on this. So no, we do not treat them any differently. All patients who've come from the community are suspected COVID, so the cath lab team are wearing appropriate protection and they come to the heart attack centre and they have angiography and PCI as they would normally do. If I could just give you my experience of what I tend to find in these patients. So the patients who have COVID, who have heart changes, tend to be extremely unwell for COVID generally. Okay. The COVID as a cause of a plaque rupture by itself is, I think, extremely unusual. The troponin rises we see in sick COVID patients, it tends to be due to, it's not actually a myocarditis, it seems to be more of a microvascular obstruction in the heart, but of course more commonly seen elsewhere in the body. So no, we take them to cath lab because they're usually having a heart attack. And you probably are aware that the COVID patients, they both clot a lot and they bleed a lot, and I suspect probably the last thing they need is fibrinolysis.
Okay, I think we're slightly over the time, but just one more question about primary prevention. Would you recommend antiplatelet use for primary prevention in those high risk, for example, diabetes? And that's from Dr. Jiju.
Gosh, that's a slightly tricky one. So the guidelines suggest if there is atherosclerotic disease, they should have aspirin. That's what it recommends. Joseph, you might be able to answer. In a diabetic who's not known to have coronary disease, I don't know that aspirin is recommended to her. Why don't you answer that one?
So I think there is some increasing evidence that they may be more at risk from side effects of antiplatelets. So I think there's been some very recent, I can't remember the trial off the top of my head, but there's been a trial that suggests that even in these high-risk patients, straightforward aspirin may not. But I think the trials need to be done with the more modern agents like clopidogrel. And there was another question about the dose of clopidogrel. You mentioned clopidogrel also is now trounced by the newer drugs, prasugrel and ticagrelor. Is that because of the loading, do you think?
Oh gosh, this is a really fascinating area, and we won't have time to fully explore it. So no, it's probably due to some degree of genetic resistance to metabolization of clopidogrel. So ticagrelor is an indirect inhibitor of P2Y12. Prasugrel is a direct inhibitor, but it's a downstream metabolite. They are both better, but this is really in ACS patients we're talking about, not stable angina patients. And we have gone with ticagrelor, which seems to be better and has less exclusions than prasugrel. But that ISAR React 5 trial that's published 2 months ago shows the opposite. Really fascinating. So we may be changing our guidelines in the near future. But prasugrel clopidogrel is effective, okay, and is affecting a lot of people, and we needed, trials with 20,000 patients to show benefit in the other patients. So it's not a bad drug, clopidogrel, and it's certainly associated with less bleeding risk.
Okay, marvelous. Thank you so much, Patrick. That was fantastic.
You're very welcome.
I think, thank you, Patrick, for taking us through the ACS scenario. It was nice going through all the cases. I'd also like to thank my two co-chairs, Dr. Cherian and Dr. Fraz Mir. We had a wonderful half a day today, and I think we are looking forward to coming up with some more talks tomorrow evening at 7:30. So please do join us, and we'll take you through another area of acute care medicine. Thank you, Fraz. Thank you, Joseph. Thank you, Patrick, for all your wonderful help. Thank you and good night.
Bye-bye. Night.